Welcome everyone to the Mental Health Professional's Guide to Addressing Medical Cannabis Use and Treatment. I'm Dr. Aaron Norton, a licensed mental health counselor, licensed marriage and family therapist, and a board-certified addictions professional with 20 years of experience providing substance use and mental health treatment and conducting clinical and forensic substance use evaluations. And I hope you find this information helpful. Medical cannabis has become a politicized topic with some strong opinions attached to it. I'm going to try to be fair in my approach in this subject, and I might as well go ahead and disclose my personal viewpoint on the issue. I describe myself as both a supporter of medical cannabis and a critic. I voted to legalize medical cannabis here in Florida, and I think it ought to be a treatment option. But I'm also concerned about incongruities between the research and practice guidelines available on medical cannabis and the way that medical cannabis is managed by some community providers and patients. I hope that whether you are a supporter, critic, or don't really have a position on the subject, you'll find this information in this video to be helpful. I already told you a little bit about myself. On this slide, you can read more about my qualifications and background if you'd like to. Also, if you have follow-up questions about this material, you can reach me using the email address at the bottom left of this screen, which is me@anorton.com. All the slides that you see here are available as a free PDF. You can use the link in the video description to access them, or you can scan the QR code on this screen. The PDF also includes embedded hyperlinks to most of the sources and resources that I'll be discussing today so that you can check those sources out for yourself. I also included a reference list in the handouts with all sources listed in alphabetical order. So here's what we're going to cover in this video. First, we discuss some basic information about cannabis, including an overview of chemicals and a neuroscience explanation for the psychoactive properties of cannabinoids in the brain. Then, we'll discuss barriers to conducting and understanding research on both the medicinal benefits and adverse effects of medical cannabis. We'll then review the positions of various medical and psychological associations, and we'll briefly compare and contrast the harm reduction and recovery models of mental health and substance use treatment and how those models play a role in the debate on medical cannabis. We'll review risk factors for developing a cannabis use disorder. We'll discuss some dosing considerations and models in the professional literature, and we'll learn about a decision model that behavioral healthcare professionals can use to guide decisions when clients or patients present with medical cannabis use in a variety of behavioral healthcare settings. We'll model how to use that matrix with some real case examples. I should tell you a little bit about why I became interested enough in the issue of patients presenting with medical cannabis use and treatment to create a related decision matrix for clinicians. One of the services I provide in my practice is clinical supervision. Interns who are pursuing licensure as mental health counselors or as marriage and family therapists staff their cases with me, and I supervise their clinical work until they've earned their licenses. When medical cannabis was legalized here in Florida, my interns started encountering some ethical dilemmas involving medical cannabis. Some of my interns worked in a community mental health agency contracted with the Florida Department of Children and Families to provide mandated substance use treatment for individuals who lost custody of their children due to substance-related abuse or neglect. To potentially regain custody of their children, parents in this program had to achieve remission from their substance use disorders. They had to refrain from using substances for several months while participating actively in treatment. The program's intention is to help parents address their substance-related problems so that they can potentially be reunited with their children without future substance-related abuse or neglect. Random urinalysis drug testing is part of the program and is one way of corroborating a client's self-report that they're no longer using. But some clients who had cannabis use disorders or other substance use disorders obtained medical marijuana cards and took the position that the treatment staff could not require them to stop using cannabis because cannabis was medically necessary for them. However, just because a client's using medical cannabis doesn't mean that they don't have a problem with it. And if nothing changes with that client, other than having a piece of paper they didn't used to have, then the risk of future substance-related abuse and neglect has not truly been addressed. Still, my interns aren't medical doctors. They can diagnose and treat mental health and substance use disorders, but they can't advise clients on what to do with their medications, placing them in a difficult position. On one hand, they have to attest that a client's in remission, meaning they've not experienced any of the symptoms of a substance use disorder for at least 3 months, and that their prognosis is good. But on the other hand, they risk allegations of practicing medicine without a physician's license if they insist that these clients have to stop using substances as part of their treatment. Similarly, some of my interns worked in treatment programs designed for people who'd been arrested for driving under the influence of a substance. Individuals arrested for DUI are evaluated, and if there's evidence that they have a substance use disorder and need treatment to reduce the risk of driving under the influence in the future, then they're referred to treatment, which they must complete successfully in order to regain or maintain their driver's license. While in treatment, they're drug tested and expected to remain abstinent from substances. Some of them go and obtain a medical marijuana card and assert that they can't be required to stop using cannabis because their cannabis use is medicinal in nature. Once again, clinicians who are experts at diagnosing and treating substance use disorders, but who are not physicians, find themselves in the uncomfortable position of needing to balance the welfare of the client with the safety of the driving public, while also avoiding allegations of practicing medicine without an appropriate license. They also have to be ethical with their treatment. They can't complete a client successfully from treatment if the client is not in remission or has a poor prognosis for the future. In both of these scenarios, the medical use of cannabis may neither be in the client's best interest nor in the best interest of other stakeholders in the process, such as their children who were removed for substance-related abuse or neglect, or people who might be injured or harmed if the client were to drive under the influence of a substance in the future. It became clear to me that my interns needed a model that was based on research and practice guidelines that they could refer to when making decisions about these cases. Alright, so now that you've heard the background for why I created that tool, let's talk a little bit about some basic definitions. Throughout this webinar, I'm going to be using the term cannabis instead of the term marijuana. Marijuana, or marijuana, is Spanish for Mary Jane, and some people argue that the term is racist, claiming that its historical origin involves prohibitionists who wanted the substance to be framed as a form of a Mexican vice. So I'm going to use the more scientific and neutral term cannabis, which is generally the term that's going to be used in research as well, and cannabis is a Latin term that simply refers to a plant. However, I think it is noteworthy that Mikos and Cam, using a variety of approaches, found no evidence to suggest that the public differentiates between these two terms. Still, I'm going to go with cannabis. The term marijuana can also be used to describe the dried leaves, flowers, stems, and seeds from the cannabis plant. There are two main species or strands of cannabis, differentiated by height, branching patterns, and shape of the leaves. Cannabis sativa originated in Southeast Asia and Central and South America, and it tends to have more THC than CBD. Cannabis indica originated in the Middle East in places like Afghanistan, Pakistan, and Tibet. It has higher CBD content as compared to sativa. The ratio is close to 1 part CBD to 1 part THC. Cannabinoids are compounds that come from cannabis or are structurally similar to compounds found in cannabis. We'll also differentiate between endogenous and exogenous cannabinoids in this training. Endogenous cannabinoids are those that naturally exist within our own bodies. Exogenous cannabinoids are those that come from outside of our bodies, including the cannabinoids that come directly from the cannabis plant. If an individual ingests cannabis, they bring it into their system, then those are exogenous cannabinoids. Now, there are a lot of cannabinoids. Researchers have discovered over 100 of them, and in truth, we don't know how many there are. But on this slide, I've listed some of the cannabinoids most commonly referred to in research. Having said that, most but not all of the time that the term medical cannabis is being used, we're referring to either delta-9 tetrahydrocannabinol, abbreviated as THC, or cannabidiol, abbreviated as CBD, the two most commonly researched and used cannabinoids. But THC and CBD are very different chemicals. Sometimes they exert similar effects as each other, and other times they have different, even opposite effects. For example, THC produces a high or euphoria and can also impair an individual's balance and coordination. CBD does not produce a high and does not appear to impair balance and coordination. There are other significant differences in the effects of THC and CBD that we'll discuss later, but here I really want to stress that when you hear the terms medical cannabis or medical marijuana, an important question to ask is, which cannabinoid are we referring to in this report or study? That makes a big difference. In the human body, there are receptor sites that cannabinoids can bind to. They're called CB1 and CB2 receptors. Though both can be found in the brain, most CB receptors in the brain and spinal cord, or central nervous system, are CB1 receptors. CB2 receptors are mostly found in the immune and gastrointestinal systems, otherwise known as the peripheral nervous system. Now, there is this important mechanism in the brain called the blood-brain barrier. The blood-brain barrier is a semi-permeable border of endothelial cells that prevent solutes from non-selectively crossing into cerebrospinal fluid where neurons reside. The blood-brain barrier's job is to try and keep toxins and dangerous chemicals out of your brain. And you might think that it would try and keep chemicals like high amounts of opioids out of the brain, for example, but obviously that doesn't happen because people overdose and sometimes die on opioids. So how does that happen? How does the blood-brain barrier let these substances in despite their lethality or toxicity? Well, it's because any psychoactive substance, any substance that produces a high or euphoria, any potentially addictive substance, gets into the brain by essentially tricking the brain into thinking that it is something that it is not. Specifically, addictive chemicals that cross into the brain chemically are structured very similarly to chemicals that we already have in our brain, like neurotransmitters. They're not exactly the same thing as our neurotransmitters, but they're very similar, close enough for the blood-brain barrier to essentially think that they are natural chemicals that exist within our brain. And obviously with cannabinoids, we're going to see no difference here. THC from cannabis, for example, looks very similar to the blood-brain barrier as anandamide and 2-AG, which are two endogenous cannabinoids. They are chemicals that exist naturally in our brain. They are manufactured in the brain and distributed, and they play a vital role in our brain's ecosystem. Anandamide is a neurotransmitter that is an endogenous cannabinoid, and it's associated with effects on memory, pregnancy, regulation of feeding behavior, motivation, pleasure, and even the experience of the runner's high. 2-AG is also an endogenous cannabinoid, a neurotransmitter, and it's present at relatively high levels in the central nervous system, and it acts as an agonist at the CB1 receptor. So essentially, when THC reaches the blood-brain barrier thinks, hey look, it's our good friend anandamide or 2-AG. And that is often not going to be the case. When THC gets into the brain, it binds to some of the same receptor sites as anandamide or 2-AG might bind to, and then it does some of the same jobs that those chemicals might do, and this is part of why we experience the high or the euphoria that we experience. But if we keep doing this over and over again, then the brain basically says, why is there so much anandamide or 2-AG all over the place? We can't function normally this way. And remember that the brain is very interested in homeostasis. It doesn't want us to stay outside of a state of normalcy for too long, so it's going to try and do something to create normalcy again. It might erroneously think that the problem is that it is producing too much anandamide or 2-AG or releasing too much of it into the brain. And so it might actually reduce its own manufacturing or distribution of those two chemicals. And that's what creates a tolerance on the exogenous cannabinoid, in this case THC. And it also is what explains withdrawal when somebody stops using THC and then they experience a period of abnormalcy while the brain tries to recalibrate and adjust and get a sense of its own chemical balance again. So we'll talk some more about that later on. All right, so we got the terms and some basic neuroscience of cannabinoids out of the way, and now let's get back to the question or the issue of medical cannabis here. First, I think it's important to note that healthcare professionals, those who are tasked with possibly recommending medical cannabis, are often very undereducated about medical cannabis. For example, in this study conducted by Gardner and colleagues in 2019, there was a review of 26 studies revealing that health professionals support the use of medical cannabis, but there's a unanimous lack of self-perceived knowledge surrounding all aspects of it, and those health professionals voice concern regarding direct and indirect harms of medical cannabis. Also, generally speaking, medical programs do not teach their students or residents about medical cannabis. So in the professional literature, we generally will see that people who are graduating from medical school or have completed their residencies are woefully undereducated about medical cannabis, and yet they are the ones who are sometimes going to be tasked with assessing candidacy for medical cannabis and possibly recommending it. So there's a great deal of work to be done on educating even physicians on medical cannabis. Remember how we talked about CBD and THC, and we briefly discussed some of their similarities and differences, but there was a report published by the World Health Organization in 2018 on CBD. And this was a pretty important report, but it was interesting to me that after this report was published, I saw some wide variation in what different media sources had to report on the report itself. And some of it was very confusing and contradictory, and I think this serves as a great example of some of the difficulties in making sense of research out there. So here are 3 different headlines about this report published by the World Health Organization. The first headline says, "Compound in marijuana appears safe and non-addictive," WHO says. The second headline, "WHO report finds no public health risks or abuse potential for CBD." The third headline, "Blow to anti-cannabis campaigners as WHO declares no health risk of medicinal marijuana." Now, some of these headlines are better than others. The third headline, the one that starts with "blow to anti-cannabis campaigners," is egregiously inaccurate and misleading because the World Health Organization did not declare that there was no health risk of medicinal marijuana. Remember that medicinal marijuana is a very broad term, and this report was only about CBD, one particular cannabinoid. The report would have looked very different if it were about THC, which does pose a public health risk, as we'll talk more about later on. So it's a very misleading headline, and you can see how some people might look at a headline like that and say, "Oh, great, so medical cannabis is safe. Wonderful." That's not at all what the World Health Organization concluded. I think the best of these 3 is the one in the bottom left, which reads, "WHO report finds no public health risk for abuse potential for CBD," because that's very accurate in terms of what WHO concluded. The first headline, "Compound in marijuana appears safe and non-addictive," WHO says, is technically not inaccurate, but it would have been nicer for them to name the specific compound in the headline so that people can have a greater awareness based on what they see in that headline. Let's explore an example of how confusing and contradictory research on medical cannabis can be. Here's a research question. Does medical cannabis alleviate adverse effects of the opioid epidemic? For example, if people have access to medical cannabis, will fewer of them take opioids? And if so, will fewer people develop problems with opiates? Might we see fewer overdoses, for example? We have decades of research on cannabis. Surely we can find an answer to this question in all that research, right? I like ScienceDaily.com. They do a pretty good job of reporting on research. If you search their archives for articles that relate to both cannabis and opioids from 2014 to the present, you'll see a variety of headlines. Here's our first one. 24% or 25% fewer opioid-related deaths in states allowing medical marijuana. Great! So I guess we have our answer, right? Medical cannabis equals fewer opioid-related deaths. Nice! And the next headline piles on, reading, marijuana could help treat drug addiction and mental health. Great! But wait a second, the next headline reads, marijuana use may not aid patients in opioid addiction treatment. New research finds that frequent marijuana use seems to strengthen the relationship between pain and depression and anxiety, not ease it. Well, maybe the conclusions we drew from those other studies were a little premature, huh? To pile on to that previous finding, here's another one. Study questions a link between medical marijuana and fewer opioid deaths. The association appears to be changing as medical marijuana laws and opioid epidemic change. Okay, so maybe medical marijuana doesn't really help with opioid-related deaths. And the next headline adds two more studies to the list, adding that 2 papers published look at the current evidence of effects of medical marijuana, and one conclusion was that there really is little support that such laws reduce opioid overdose deaths. So maybe medical marijuana doesn't reduce opioid-related deaths. But then the next headline reads, legalized medical cannabis lowers opioid use. Study finds, okay, so maybe it doesn't reduce opioid-related deaths, but it does lower opioid use? Okay, interesting. This study focused on older adults, resulting in a finding that up to 65% of older adults who used medical marijuana significantly reduced their chronic pain and their dependence on opioid painkillers. To add to the previous study, this study concludes that medical and adult use cannabis laws were associated with lower opioid prescribing rates. Okay, so maybe in places where there's medical marijuana legalized, there fewer physicians are going to prescribe opiates. But hold on just a second. This next headline says that people who use medical marijuana are more likely to use and misuse other prescription drugs. That's interesting. So now we're saying that medical marijuana actually increases the probability of misusing prescription drugs like opiates? Oh boy, I thought that we had this figured out a few studies ago. More definitively, the next headline reads, medical marijuana does not reduce opioid deaths. Short, simple, and sweet, huh? Except that the next headline says marijuana legalization reduces opioid deaths. That's the opposite of what we just read, isn't it? The next headline gets more complicated. Daily cannabis use lowers odds of using illicit opioids among people who have chronic pain. Okay, so it's maybe only if they use cannabis a lot and they have chronic pain that we're less likely to see them using opioids. Okay. But hold on now, the next headline reads, cannabis use appears to encourage, not replace, non-medical opioid use. Man, this is the opposite of what we just saw a moment ago. But it now looks like the tennis ball has been smacked into the opposite side of the court again, because the next headline reads, legal cannabis stores linked to fewer opioid deaths in the US. Okay, so maybe it's not the medical cannabis itself, it's just having more stores in an area that is related to fewer opioid deaths? Okay. People with fibromyalgia are substituting CBD for opioids to manage pain. Okay, well, this is interesting. I remember CBD is different than THC from cannabis, but maybe at least for people with this particular condition, there might be some evidence that they're substituting a form of medical cannabis for opioids for pain management. Okay. The next headline definitively declares recreational marijuana access reduces demand for prescription drugs. Okay, well, opioids are prescription drugs, so all right. This report goes so far as to say that in a new study, opioid use is seen to reduce or stop altogether following prescription of medical cannabis. If you're confused by that roller coaster ride constituting our magical journey through the last 10 years of Science Daily headlines about research on medical cannabis and the opioid epidemic, then you're in good company. I counted 9 studies suggesting that medical cannabis in some way reduces the adverse effects of the opioid epidemic, and 8 studies suggesting that it does not. What concerns me is that I've attended trainings in which presenters cherry-pick the studies they want you to hear about and leave the rest behind. So you could attend a training and feel convinced that medical cannabis alleviates the horrors of the opioid epidemic, and you could potentially attend a different training in which the presenter only told you about the 8 studies suggesting that medical cannabis does not alleviate the opioid epidemic or even makes it worse. So be wary of anyone who handpicks a few studies here or there and then tells you that the science is settled. Why do studies exploring similar research questions yield different results? Well, researchers use different methods to arrive at their conclusions, and of course, some of those methods are going to be better than others. Then there's always the question of what sample the researchers are using, how they obtain that sample, and whether that sample is representative of the population they're researching, and all that's just the tip of the iceberg. So, what would the perfect study exploring the medicinal benefits and adverse effects of medical cannabis look like? Well, that would probably be a mixed methods randomized controlled trial, or RCT. You'd have to obtain a large sample of people, young and old, who are representative of the overall population, and you'd have to randomly assign them to different groups. You'd have an experimental group, which would receive medical cannabis. You'd divide that group into subgroups of varying doses. You'd have a placebo group, which might, for example, be given a pill that does nothing, and you'd have a control group that gets no pill. You'd then administer THC in different doses, placebo or nothing, for decades, covering each person's entire life, and then you'd carefully measure differences in their medical symptoms and their adverse effects in a decades-long longitudinal study, while somehow ensuring that they're not taking any cannabis that you didn't give them along the way. As you can guess, this study's never been done, and I feel confident it never will be done. Not only would it be incredibly time-consuming and expensive, but it would never get approved by an institutional review board. Hey, I know that there's a lot of research indicating that exposure to THC can be harmful to people's brains, but let's just give them THC for their entire life and see how messed up they get. That's not going to fit the ethical prerogative of doing no harm, right? Especially for kids. So what do we do instead? We do short-term RCTs, but those studies don't tell us much about the long-term effects of medical cannabis. Or we could do correlational studies where we find people who do and don't use medical cannabis, and then we measure differences between their outcomes while trying to statistically control for as many variables as we can. But when it comes down to it, that's still just correlational research. Correlation or relationship does not prove causation. For example, I once participated in a study in which we demonstrated that the average youth in Pinellas County, Florida, who'd been arrested and tested positive for THC had a grade point average of 1.3, whereas the average student not testing positive for THC had a 3.0 GPA. Does that prove that THC use causes poor grades? No. It just shows that the two variables are related. What if, for example, kids who get lower grades are more likely to experience negative thoughts and feelings and therefore more likely to use THC? Well, in that case, the THC would not be causing the lower grades, it would be caused by the lower grades. Finally, we can use animals for studies, such as rats. But rats have about a 2-year lifespan, and we really don't know that what happens to rats in 2 years will be similar to what happens to humans after decades of using a substance. Not only do we have all of these limitations to cannabis research, but there are also regulatory hurdles, as cannabis is a Schedule I controlled substance, although that could change soon, and therefore it's harder to get research approved on cannabis. Okay, so you might be kind of feeling hopeless about what research can and cannot tell us about medical cannabis, but I'm going to try and help you feel a little bit better about that in just a little bit here. Before we do that though, just a little side note, a quick segue into medical cannabis and the law. I just got done telling you that research on medical cannabis can be harder to get approved because cannabis is a Schedule I substance. So the Controlled Substances Act created 5 distinct categories of substances depending on the drug's acceptable medical use and drug abuse dependency potential. And Schedule I is reserved for substances for which there's no currently accepted medical use and a high potential for abuse. And guess what? Cannabis is in this category. It's a Schedule I substance under federal law. And that makes it very difficult to get research approved for cannabis. But that could change in the near future. On May 1st, 2024, the Department of Justice proposed to move cannabis from Schedule I to Schedule III. But they have not yet published a final rule on the matter, so it could be that even by the time you're watching this recording, that cannabis has been moved from Schedule I to Schedule III, and that might mark the beginning of more expansive research on cannabis. We'll have to see. While we're on the subject of medical cannabis and law, I do want to point out that even though medical cannabis might be legal under your state's law, it isn't currently legal under federal law. And so because of that, individuals who work in safety-sensitive occupations cannot use it, even if it's legal in their state. Safety-sensitive occupations can include being like a bus driver or a ship captain, or assembling circuit boards that go onto planes, or painting bridges for that matter. In most states, employees who use medical cannabis can be terminated by employers. For example, I have a client who was recently terminated from his job because even though he had a medical card, because he had an injury in a work site post-accident evaluation included a drug test, and he was terminated. Physicians cannot prescribe medical cannabis because prescriptions are regulated by federal law, and so they can instead only recommend it in states in which it is legal, because recommendations are a matter of free speech and are not prescriptions. This will have some implications for medical cannabis that we'll talk about in just a little bit here. So given all the confusion about conflicting and contradictory research findings on medical cannabis as well as adverse effects of cannabis, wouldn't it be really nice if a trustworthy, authoritative group of scientists would sift through all that research and then just tell us how confidently we can draw certain conclusions of medical cannabis? Wouldn't that be really helpful? Well, good news. I would argue that such a resource does indeed exist. It's a 440-page report published in 2017 by the National Academies of Sciences, Engineering, and Medicine, which was founded in 1863. They essentially reviewed the totality of research available on both the medicinal benefits of cannabis and the adverse effects of cannabis and provided this in-depth report, which also serves as a great treatment for insomnia if you read it at night, but that's another story. If you read this report, you will note that they provide different levels of evidence. For example, they might say that the research available would be conclusive on a particular matter, or it would be very limited or very little research. This could be really helpful for us. We've already seen that different studies exploring similar research questions on medical cannabis will often arrive at different conclusions. We've talked about how these different conclusions can be partially explained by differences in study designs. Given these differences, I think it's very helpful to shift focus from isolated studies to a big picture perspective. Systematic reviews, especially those involving meta-analyses, often better enable us to draw conclusions on research questions because they zoom out, examining the totality of research on a topic before drawing conclusions. Well, maybe not the totality of research because they do weed out studies that don't meet certain inclusionary criteria. For meta-analyses, researchers use the data from multiple studies to calculate what's called an effect size, which is a statistic that tells us how much effect one variable has on another. So, for example, we could identify what the effect size is for medical cannabis when it's used to treat anxiety disorders by calculating the extent to which use of medical cannabis impacts, whether by decrease or increase, symptoms of anxiety disorders. As a rule of thumb, in this example, we'd want to see an effect size of at least 0.2 to consider the effect of medical cannabis on anxiety disorders to be small, 0.5 for that effect to be described as medium, and 0.8 for it to be identified as large. Sadly, it doesn't look like meta-analyses at this time give us much clarity on the complicated question of whether medical cannabis impacts the opioid crisis in the US. Here are a couple quotes from meta-analyses researching this issue. Despite rigorous self-reporting from patients who attribute their reduction or cessation of prescribed medication to the use of medical cannabis, most results are mainly drawn from observational studies. Few good quality randomized controlled trials, or RCTs, explore cannabis substitution effects. Remember, RCTs are a gold standard for helping us to understand whether a particular treatment really significantly impacts an outcome. Here's a second one. A systematic review and meta-analysis found that while people who use cannabis are disproportionately more likely to initiate opioid use and engage in problematic patterns of use than people who do not use cannabis, the low quality of the evidence must be considered when interpreting these findings. So in other words, we just really don't have high quality enough research designs to really say much about this issue, and I think that the results of these meta-analyses illustrate why I think it's problematic for researchers, clinicians, and presenters to tell people that the science is settled on this issue. But let's go back for a second to that 2017 publication issued by the National Academies of Sciences, Engineering, and Medicine. And I've got a good question for you. Evidence supports moderate to high efficacy of medical cannabis for which disorders? There were some disorders for which medical cannabis does seem to be able to effectively treat, at least sometimes. What are those conditions? What do you think they might be? Here they are. NASEM concluded that there was at least moderate evidence of clinical efficacy of medical cannabis for the following conditions: chronic pain in adults, reduction of chemotherapy-induced nausea and vomiting, reduction of patient-reported spasticity secondary to multiple sclerosis, and short-term sleep outcomes in individuals with sleep disturbance associated with several conditions, including obstructive sleep apnea syndrome, fibromyalgia, chronic pain, and multiple sclerosis. Some of these make a lot of sense to me. For example, let's look at reduction of chemotherapy-induced nausea and vomiting. One of the places in the brain that has a large concentration of CB1 receptors that cannabis or THC can bind to is the hypothalamus. We talked about that a little bit earlier. And the hypothalamus, among many other things, regulates different drives within your system, such as the hunger drive. And in the case of THC from cannabis, this activation sort of convinces the brain that you're kind of starving and that you need sugars, fats, and carbs and calories now. That's called the munchies. And so it wouldn't be too surprised that if you had a patient who was struggling for their life, in their fight against cancer. And they were participating in chemotherapy, and because of the chemotherapy, they couldn't really stomach nutrients. That maybe medical THC from cannabis could help them to stomach their nutrients and could be very helpful in such a case. Now, I've heard some colleagues teach people that the NASEM study proves that cannabis is safe and highly effective for a variety of medical conditions. I think that's a significant exaggeration of the report's findings. In fact, I think it's more accurate to say that the NASEM report shows that there's overall very little support in favor of medical cannabis, with the exception of a small number of conditions. Here's a chart that depicts the number of conditions categorized by levels of evidence. Those levels include no or insufficient evidence, which means that either cannabis was demonstrated to not be effective for a condition, or there just isn't enough evidence that it does help for a condition. Limited means there's a small amount of evidence, but not enough to draw any conclusions. Moderate means that there's a medium level of evidence suggesting cannabis was helpful. Substantial means a lot of evidence supports that helpful effect. And conclusive basically means that the evidence is strong enough that we should consider it a fact. As you can see from this chart, for 16 conditions, cannabis is either not helpful or there's not sufficient evidence to suggest that it's helpful. And there are 4 conditions for which there is at least moderate evidence that cannabis is helpful. This doesn't look to me like some sort of A+ report card supporting medical cannabis as a particularly effective wonder drug. Now, there is a problem with that NASEM report. It was published in 2017, and that was years ago. It's a little outdated now, isn't it? But fortunately, other researchers have tried to pick up where NASEM left off. For example, Ugel and colleagues updated NASEM's work. Their specific intention was to try and update what NASEM did using more recent research. They found strong evidence of clinical efficacy for only 2 conditions. Those included epilepsy and chronic non-cancer pain. McDonough and researchers reviewed 18 randomized placebo-controlled trials, finding evidence that medical cannabis was effective for short-term relief of neuropathic pain, described as burning and tingling, but there was very little overall effect for the treatment of chronic pain. And so that raised the question of whether chronic pain ought to be removed from the list of conditions that medical cannabis can successfully treat. Abrams conducted a research review concluding that despite preclinical evidence and social media claims, the utility of cannabis, cannabinoids, or cannabis-based medicines in the treatment of cancer remains to be convincingly demonstrated. With an acceptable safety profile, cannabis and its congeners may be useful in managing symptoms related to cancer or its treatment. So in other words, Abrams concluded there's really not good evidence that medical cannabis is helpful for the treatment of cancer. So to summarize, meta-analyses and research reviews would suggest that there's moderate to substantial evidence that medical cannabis can be helpful for a relatively small number of conditions, including the following: chronic non-cancer pain, short-term relief of neuropathic pain, epilepsy, reduction of chemotherapy-induced nausea, reduction of patient-reported but not physician-measured spasticity secondary to multiple sclerosis, and short-term sleep outcomes in individuals with sleep disturbance associated with obstructive sleep apnea syndrome, fibromyalgia, chronic pain, and multiple sclerosis. Maybe future research will enable us to expand this list, but this is what we have for now. Personally, I would like for medical cannabis to be an option for those who experience these conditions and others for which future research might support. But you may notice that a lot of patients use cannabis for conditions that aren't on this list. In fact, in my practice, most of the clients I've worked with do not use medical cannabis for any of the conditions on this list. I've I've had clients use cannabis for headaches, test anxiety, sleep problems, ADHD, anxiety, depression, trauma, and stress-related disorders, none of which appear on this list. Now, of course, I've had no shortage of clients who use medical cannabis who have admitted that they aren't really using it for medicine so much as for recreational purposes, but they'd like to evade legal consequences for using it recreationally, so they obtain a medical card. But I'm not talking about those clients right now. I'm talking about those who report that their medical cannabis is helping them with conditions that are not on this list. I've also noticed that some of these clients report that their cannabis is reducing their anxiety, but I don't see overall score changes in anxiety-related symptom questionnaires over time that support their belief and/or do not see improvements in their overall functioning that might be expected when one's anxiety is reduced. I've had lots of adolescent clients who report that their cannabis use helps them to think clearly and study more, denying that it has any negative impact on their schooling. But then I might notice that their grades are actually lower now than they were before they started using cannabis. This raises an interesting question. How do we make sense of the self-report of patients who say that medical cannabis is helping them, even when we don't have evidence using objective measures that it is? Well, there are a lot of possible explanations for this phenomenon. First, maybe some of these patients are right. Maybe they're exceptions to the research findings. After all, there are always statistical outliers, right? Or maybe cannabis does help them for a brief moment without improving the overall condition. For example, if a client were feeling anxious and she vapes THC, she might feel less anxious for a little while or maybe even euphoric, but she might be just as anxious or even more anxious after the effect of the THC's worn off than she was before she used it. If so, then we could say that her cannabis use helped her in that moment. We could also argue that her experience is not truly medicine. Here, it might help to offer examples using other substances. Fun fact about me, I like singing karaoke. Well, sometimes I like singing karaoke. In truth, I often feel nervous if I'm singing in public. I found that when in international waters on a cruise ship, I can reach a point in which my karaoke-related anxiety reduces enough for me to sing and to actually enjoy the experience. This usually happens after a couple alcoholic drinks. Given that alcohol relieves my anxiety about singing karaoke, is it wise for me to frame alcohol as a medical intervention to treat my karaoke phobia? Should my physician recommend it for me? Should I be able to get a prescription for it or bill my insurance for my drinks? It's an interesting question, isn't it? I found that most practitioners don't think that alcohol should be a treatment for anxiety, even though it sometimes lowers people's stress or anxiety in the moment. Why? Is it because they don't think I should be drinking alcohol every time I'm feeling anxious about something? Is it because they think I'm capable of singing karaoke without drinking and should focus on doing so instead? Is it because they're worried about the adverse effects of alcohol as a medication? Is it because they're concerned that my alcohol might actually increase my anxiety in the grand scheme? What if I condition my brain to essentially need alcohol in order to try and function? What if it actually becomes harder over time for me to sing karaoke without drinking? What if alcohol helps in the short run, but exacerbates my anxiety in the long run? Another reason why a patient might conclude that medical cannabis is helping them with anxiety, stress, depression, or sleep problems when the evidence available does not support their claim might have to do with withdrawal. If such a person uses THC regularly for weeks, months, or even years, and then they stop using or cut back on their use, they're likely to experience cannabis withdrawal, which might include irritability, anger or aggression, nervousness or anxiety, sleep difficulty, decreased appetite or weight loss, restlessness, depressed mood, and physical symptoms causing significant discomfort from stomach pain, shakiness or tremors, sweating, fever, chills, or headache. At that time, it's understandable that a patient might interpret the sudden emergence or increase in these symptoms to be evidence that cannabis was helping them, when in reality their use of cannabis is what actually created the phenomenon of withdrawal. This is no different than how someone who's addicted to cigarettes might start to get irritable or stressed or struggle with sleep if they haven't had a cigarette in a while. But if such a person gives their brain and body time to recalibrate, the tolerance will eventually lift, and they'll probably notice much lower levels of anxiety, depressed mood, irritability, and sleep difficulty. Another reason some people might think that cannabis helps them when there's no evidence to support it has to do with the process of addiction and related defense mechanisms such as denial and rationalization. Essentially, when we're doing something we like or that feels good to us, even if there's evidence that it's problematic, we search for reasons to justify continuing with that behavior. This creates a bias. Social psychologists might refer to it as confirmation bias. We can easily overlook the evidence that a medication is harmful, and we can become overly vigilant for any evidence that it could be helpful. And we wouldn't necessarily know that this is happening. Cognitive dissonance theory offers a helpful metaphor for us to understand this phenomenon. If we look in the mirror and see something we don't like, we have a few options. We can change what we don't like about ourselves so that we now like what we see. Alternatively, we can distort the mirror, like a funhouse mirror of sorts, in such a way that we now like what we're seeing even though it isn't a true reflection of reality. Finally, we could just avoid mirrors. If we apply this metaphor to someone who believes cannabis is treating their anxiety in spite of contradictory evidence, changing oneself so that you like what you see in the mirror would probably involve quitting or reducing cannabis use. Distorting the image so that you like what you see even though it doesn't reflect reality could symbolize efforts, whether intentional or unintentional, to rationalize your cannabis use. Avoiding the mirror might include avoiding discussions with people in your life who are concerned about your cannabis use. For example, some of my clients who use medical cannabis avoid telling their primary care physician or their psychiatrist because they already know that their PCP or psychiatrist doesn't think that medical cannabis is medically appropriate for them, and this is why they go to a specialty clinic to get a recommendation for cannabis from a different provider. As is the case with all medications, helping professionals are tasked with performing a cost-benefit analysis. The question is this: is the expected or actual benefit of medical cannabis greater than its cost? Meaning risks and adverse effects of cannabis. That's an important question, one that has to be answered on a case-by-case basis. On that note, let's now transition to an exploration of the research on the adverse or negative effects of cannabis. Let's start that process with what looks like a simple question. Is cannabis addictive? To answer that question, we should first define addiction. Here are a couple authoritative definitions of addiction. The National Institutes on Drug Abuse define addiction as a chronic, relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. The American Society of Addiction Medicine, or ASAM, defines addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. The definition of addiction that I use seems to fit every definition I've read from any authoritative source, and here it is. Addiction involves repeatedly engaging in a rewarding behavior despite significant impairment or distress. So, to answer the question of whether cannabis is addictive, we'd have to answer the question, do some people repeatedly engage in cannabis use despite significant impairment or distress? If so, then cannabis is addictive. More than 10 years ago, I was watching a debate on a show called Political Connections, in which a prominent attorney, John Morgan, the owner of Morgan & Morgan, the popular law firm in Florida and Georgia, said that nobody's addicted to marijuana. This was perplexing to me, as by that point, I'd been treating people with cannabis use disorders for about 13 years. I was concerned that an attorney who was not a healthcare professional was misinforming the public, so I expressed my concerns to moderators of that show, who passed the issue on to PolitiFact, a Pulitzer Prize-winning site run by editors and reporters from the Tampa Bay Times Florida newspaper and some related news entities. PolitiFact is a fact-checking website that rates the accuracy of claims by elected officials and others who speak up in American politics. PolitiFact interviewed me, other experts on cannabis use disorder, and researchers at places like the University of Miami and the National Institute on Drug Abuse, and they rightfully concluded that John Morgan's statement was false. Cannabis is addictive. To his credit, John Morgan acknowledged that he misspoke, but he then refocused on his intended message. He proposed that although cannabis is potentially addictive, so are other medications that are commonly prescribed, such as opioids. Therefore, the mere fact that cannabis is potentially addictive should not exclude it from being a medication option. I think this is actually a very reasonable perspective and one that I personally agree with. I just wanted to make sure that when debating this important issue, we're not intentionally or unintentionally misinforming the public, especially on an important and popular news show such as Political Connections. By any definition of addiction from any reputable source, I see no way that anyone could accurately state that cannabis is not addictive. And every time that an authoritative organization explores the issue, the conclusion is always the same. Yet every couple of years, a national media organization will nonetheless reach out to me and re-ask the same question that we've answered for decades, always arriving at the same conclusion. For example, here's a headline from an article published in Salon magazine after I was interviewed about the same question. I again want to state that John Morgan had a good point. Here, for example, is a chart depicting the findings of the World Health Organization's efforts to calculate disability-adjusted life years attributed to various disorders. This is a dramatic and challenging undertaking. A disability-adjusted life year is the sum of years of life lost due to premature mortality and years of healthy life lost due to disability, due to prevalent cases of the disease or health condition in a population. The World Health Organization found that 646.5 disability-adjusted life years are lost per 100,000 people in the world due to cannabis use disorders. That's no number to dismiss. It's a significant finding. Yet, at the same time, look at the number of disability-adjusted life years per 100,000 people for opioid use disorders. That number is 14,782, which is obviously much greater than the number we saw for cannabis use disorders. If it is legal to prescribe opioids in the United States, then why shouldn't it be legal to prescribe medical cannabis? Here's a trivia question for you. Can someone overdose on cannabis? What do you think? The answer, according to both the Centers for Disease Control and Prevention and the National Academies of Sciences, Engineering, and Medicine, is yes. Especially when ingesting high quantities of edibles. But it's highly unlikely that it would be fatal to do so. I've never seen evidence of a single case of a person dying from an overdose on cannabis. Instead, overdoses often involve nausea, vomiting, and possibly paranoia. In 2016, PolitiFact analyzed a claim made by Gary Johnson, a former Republican governor of New Mexico and a Libertarian presidential candidate. Johnson claimed that legal prescription drugs, quote, statistically kill 100,000 people a year, but there are no documented deaths due to marijuana, end quote. PolitiFact rated this statement as half true, because cannabis is implicated in deaths, but not through overdose. If that's the case, what are these so-called cannabis-related deaths about? Every year, there's a particular date in which cannabis-related motor vehicle accidents, emergency department visits, and related deaths increase starting in the mid to late afternoon and progressing through the night. This surge of incidents starts on the eastern coast and then works its way one time zone at a time across the US, ending in Hawaii. On what date do you think this happens? The answer, as you might have guessed, is April 20th, also known as 420, a date in which cannabis enthusiasts celebrate their treasured pastime by lighting up or vaping. Sometimes when people are under the influence of cannabis, they'll make decisions they wouldn't normally make, or make mistakes they wouldn't normally make. They might drive under the influence of cannabis when motor coordination, reaction time, and decision making are impaired, or they might engage in other dangerous behaviors they normally wouldn't. So it's not true that cannabis use doesn't sometimes cause deaths, but it is true that those deaths are probably not from an overdose. They're probably from impaired behaviors. I really like the meta-analysis conducted by Solmi and colleagues and published in 2023 because it factors a vast number of studies, specifically 101 meta-analyses, and since each meta-analysis is a review of multiple studies, I can't even guess how many studies are involved in this data. It's got to be monumental. A second reason I like this meta-analysis is that it explores both the medicinal benefit of cannabis and the adverse effects of cannabis in one study. So let's explore some of those findings in the next several slides here. For people with mixed conditions, medical cannabis was associated with adverse events related to the central nervous system, psychological effects, and vision. Improved nausea and vomiting, pain and spasticity, and increased psychiatric gastrointestinal adverse events, as well as somnolence. Somnolence is essentially sleepiness, a drowsiness, a strong desire or inclination to sleep, and is a very common adverse effect of cannabis use. For patients who experience seizures, CBD was associated with a 50% reduction in seizures and seizure events, but it increased pneumonia, gastrointestinal adverse events, and somnolence. For patients with chronic pain, cannabis-based medicines reduced pain by 30% across different conditions, but increased overall psychological distress. For epilepsy, CBD increased the risk of diarrhea, had no effect on sleep disruption, reduced seizures across different populations and measures, and improved global impression and quality of life, but also increased the risk of somnolence. In the general population, cannabis is associated with increased psychosis, worsened positive psychotic symptoms and total psychiatric symptoms, negative symptoms, and cognition. For patients with inflammatory bowel disease, cannabis was associated with improved quality of life. For patients with multiple sclerosis, it was associated with improved spasticity and pain, but it also increased the risk of dizziness, dry mouth, nausea, and somnolence. For patients with cancer, cannabis was associated with improved sleep disruption, but with gastrointestinal adverse events. Cannabis is generally associated with poor tolerability across various conditions. This, I think, is a really important point to ponder for a moment. See, patients who are assigned to medical cannabis in randomized controlled trials tend to not tolerate it very well overall. They generally don't like the medical cannabis, and they generally find that it's more of a problem than it is helpful, and so they'll tend to want to stop using it. That's not true among those who have medical marijuana cards here in Florida, for example. That's because the people who have cards are self-selected. They chose to get cards. But in the general population, people who aren't necessarily choosing a card, that are just randomly assigned to the medical cannabis group due to some other treatment condition, tolerability is very poor. And this suggests that there's something different about patients who seek out a card that separates them from the general population. That's a very interesting point that we'll be coming back to later on. For pregnant patients, medical cannabis is associated with a smaller size and low birth weight for newborns. For drivers, it's associated with increased motor vehicle accidents. And for healthy users, that means those without any particular medical or psychiatric conditions, medical cannabis is associated with increased psychotic symptoms, suicide attempts, depression, and mania, as well as impaired cognition. Gilman and colleagues published a particularly interesting study about medical cannabis. They randomly assigned 186 adult participants with concerns related to anxiety, depression, insomnia, and chronic pain to two groups. One group was given immediate medical cannabis card access, but the other group had to wait 12 weeks to get that access. Participants with immediate access were nearly 3 times as likely to develop a cannabis use disorder. Those who obtained the card immediately showed no significant improvement in anxiety, depression, and pain relief as compared to the delayed card group, with the exception of self-reported reduced insomnia. How do we make sense of this finding? Well, one theory is that for anxiety, depression, insomnia, and chronic pain, if you delay giving patients access to medical cannabis, then they'll find and use other strategies for addressing those medical problems that they'll find helpful. And if you give them medical cannabis a few months later, they're therefore less likely to over-rely or depend on cannabis because they already have effective medical and psychosocial tools on their belt. But if you make medical cannabis the first line of treatment, as was the case for the immediate access group, then patients are less likely to develop other coping strategies, including those that may be safer or even more effective. And those patients are therefore more likely to overuse and overdepend on cannabis, leading to a cannabis use disorder, which is essentially an addiction to cannabis. Now, remember that comprehensive report published by the National Academies of Sciences, Engineering, and Medicine in 2017 that concluded that there was at least a moderate amount of evidence suggesting that medical cannabis was useful for a relatively small number of medical conditions? Well, that same report examined the evidence that cannabis was harmful and that users risk certain adverse effects of cannabis use. What were their findings in that area? Well, they included increased risk of non-seminoma type testicular germ cell tumors, triggering of acute myocardial infarction, which is a heart attack, ischemic stroke or subarachnoid hemorrhage, increased risk of prediabetes, worse respiratory symptoms and more frequent chronic bronchitis episodes, increased risk of developing COPD even when controlled for tobacco use, increased risk of motor vehicle crashes, increased risk of overdose injuries, including respiratory distress among pediatric populations, lower offspring birth weight, and increased risk of pregnancy complications for mothers using cannabis, impairment in the cognitive domains of learning, memory, and attention, impaired academic achievement and education outcomes, increased rates of unemployment and/or low income, impaired social functioning or engagement in developmentally appropriate social roles, the development of schizophrenia or other psychoses with the highest risk among the most frequent users, increased symptoms of mania and hypomania in individuals diagnosed with bipolar disorders, a small increased risk for the development of depressive disorders, increased incidence of suicidal ideation, suicide attempts, and suicide completion, increased risk of social anxiety disorder, bipolar disorder, anxiety disorders, and anxiety symptoms, worsening of negative symptoms for individuals with schizophrenia, and increased severity of symptoms for people with PTSD. As we've already discussed, NASEM's report is now a little outdated, having been published in 2017, so I've included a little information about more recent trends in research on adverse effects of cannabis. One setting that's ripe with such research is emergency department visits. Crocker and colleagues reported in 2021 that cannabis-related emergency department visits have been increasing in recent years, especially among youth and young adults, and in areas where cannabis has been legalized. Conditions related to these increases include cannabinoid hyperemesis syndrome, or some people pronounce it hyperemesis syndrome, and this is a condition that involves nausea and vomiting, uncontrolled and severe nausea and vomiting, that is caused by heavy and sustained cannabis use. And what's interesting about this condition is that people who experience it have a difficult time accepting the conclusions of medical staff that their cannabis use is causing the problem. Because they'll say, well, I've been using cannabis for months or years and I've never had this problem before, so it clearly can't be cannabis use that's causing it. But there's a certain critical threshold in which the brain decides that something really toxic is going on here. And the only solution it seems to be able to conjure up is to just try to expel everything. And so these individuals are experiencing severe and uncontrollable nausea and vomiting, and they'll present to the emergency department with these concerns, and it'll be diagnosed as being cannabis related. Additional conditions include lung injury related to vaping, arrhythmias, head and body trauma from cannabis-related motor vehicle accidents, injuries such as falls, and cannabis-induced anxiety, suicidal thoughts, and psychotic or attenuated psychotic symptoms. Sadly, up to 50% of patients with cannabis-related psychotic symptoms presenting to the ED requiring hospitalization will go on to develop full-blown schizophrenia. This is particularly sad because these individuals may have never developed schizophrenia had they never started using cannabis. Though there is still certainly some debate about this question, a lot of research does associate the legalization of medical cannabis with increased cannabis use rates, including among adolescents and young adults, even though for adolescents, medical cannabis is almost never legal. So we do have to kind of accept that when we do legalize medical cannabis, adolescents and young adults might use more of it, at least at first. Another adverse effect of medical cannabis that has received scant attention until recent years involves problematic interactions between cannabis and other medications that patients might be taking. This research review, published by Lopera and colleagues in 2022, offers 4 levels of risky interactions based on a combination of the severity of the adverse effect and the probability of such an effect. Kosis and Brana offer a list of medications that negatively interact with medical cannabis. We won't get into these nitpicky details now. After all, you can always look at these lists later. You have hyperlinks to these studies, but an important consideration for physicians as well as mental health professionals working with patients who are pursuing medical cannabis or are using it involves determining whether there's reason to suspect that their cannabis use could pose a danger to them based on whatever other medications they might be taking alongside their cannabis regimen. So we've now reviewed research on the efficacy of medical cannabis for various conditions, as well as research on adverse effects of cannabis. Let's now shift our focus to the positions of various medical and psychological associations on medical cannabis. What do they think about it? So here's a question for you. What medical or psychological associations do you think endorse medical cannabis? Well, I think you'll be looking pretty hard to try and find a particularly enthusiastic endorsement. But let's see as we go through some of the positions of these associations. Let's start with the position of the American Academy of Ophthalmology. Now, I'll preface this by acknowledging that I previously assumed that there would be great evidence that medical cannabis could effectively treat glaucoma. But as it turns out, I was wrong. I mean, you saw the report from National Academies of Sciences, Engineering, and Medicine. They concluded that there was not evidence that cannabis could effectively treat glaucoma, and neither did subsequent researchers when publishing their meta-analyses. So let's look at their position. AAO says that glaucoma and other eye conditions cannot be treated by cannabis because eye pressure has to be managed 24 hours a day to effectively treat glaucoma. And it's simply not practical to use cannabis constantly. To reduce and maintain eye pressure noticeably, a patient would have to ingest 18 to 20 milligrams of THC 6 to 8 times a day, which would adversely impact mood, mental clarity, lung health if smoked, capacity to drive or operate heavy machinery, and engage in many other daily activities, as well as being cost prohibitive for the average patient. Additionally, the optic nerve isn't just damaged by high eye pressure. It's also damaged by low blood flow and pressure, which cannabis can adversely affect, thus potentially damaging the optic nerve of patients with glaucoma. So it really doesn't look like medical cannabis is a good treatment for glaucoma. Here's the position of the American Academy of Pediatrics. Given the data supporting the negative health and brain development effects of marijuana in children and adolescents ages 0 through 21 years, the AAP is opposed to marijuana use in this population. Notwithstanding this opposition, the AAP recognizes that marijuana may currently be an option for cannabinoid administration for children with life-limiting or severely debilitating conditions and for whom current therapies are inadequate. And the AAP supports research and development of pharmaceutical cannabinoids and recommends changing marijuana from a Schedule I to a Schedule II drug. So this was not exactly an enthusiastic endorsement, but they are saying that cannabis ought to be an option for some children with life-limiting or severely debilitating conditions who are not responding to other current therapies. How about the American Heart Association? They say that cannabis may have therapeutic benefits, but few are cardiovascular in nature. Conversely, many of the concerning health implications of cannabis include cardiovascular diseases, although they may be mediated by mechanisms of delivery. So the AHA suggests that we harmonize laws on all levels, including removing cannabis from Schedule I, that we remove legal barriers to research, create surveillance and monitoring and public education infrastructure, integrate cannabis into tobacco control and prevention strategies, support laws preventing use among minors, support FDA regulation of products, support clear dosing standards, standardize education and training for healthcare professionals, educate about cannabis interactions with other drugs, educate public about the short-term and long-term health consequences of cannabis use, dispel myths about the efficacy of medical cannabis, establish standards for measuring intoxication and impairment, and educate about cannabis use disorders. The American Heart Association further observes that medical cannabis can negatively affect cognition as well as increasing risk of stroke, raising concerns about its potential long-term effects. The American Medical Association observes that scientifically valid and well-controlled clinical trials conducted under federal investigational new drug applications are necessary to assess the safety and effectiveness of all new drugs. And of course, cannabis products are no exception. They say that cannabis for medicinal use should not be legalized through the state legislative, ballot initiative, or referendum process. They believe that the following warning should be placed on all FDA-approved cannabis products. Quote, marijuana has high potential for abuse. This product has not been approved by the Food and Drug Administration for preventing or treating any disease process, end quote. They also favor physician immunity against federal prosecution when certifying approval for a medical marijuana card. And they favor free and unfettered exchange of information on treatment options. But they encourage hospitals and health systems to not recommend non-FDA approved cannabis products and to educate providers on cannabis use, its effects, and cannabis withdrawal syndrome. Despite the claims of some of my colleagues, this does not look like a glaringly positive review of medical cannabis by any means. The American Nurses Association observes that the finding of anecdotal and controlled studies regarding the efficacy for patient use are mixed. So they recommend a scientific review of the DEA's schedule status of cannabis, the development of specific evidence-based prescribing standards, and protection from civil and criminal sanctions for patients using medical cannabis for therapeutic purposes, and healthcare practitioners who discuss and administer medical cannabis in accordance with professional standards and state laws. The American Psychiatric Association observes that there is no current scientific evidence that cannabis is in any way beneficial for the treatment of any psychiatric disorder. In contrast, they observe that current evidence supports at minimum a strong association of cannabis use with the onset of psychiatric disorders. They think that adolescents are particularly vulnerable to harm and that further research on medical cannabis is needed. That they observe that there is great variability in the form, dose, and potency of cannabis and related health effects. They say that policy and practice surrounding cannabis-derived substances should not be altered unless sufficient clinical evidence supports such changes. And that if and when scientific evidence does support the use of cannabis for certain conditions, cannabis medicine should be subject to the FDA approval process. The APA issued an additional statement specifically about medical cannabis for PTSD. They declare that because of the lack of any credible studies demonstrating clinical effectiveness, they can't endorse the use of medical cannabis for the treatment of PTSD. They reported that the Council on Addiction Psychiatry, the Council on Research, and the Council on Quality Care reviewed available evidence regarding the use of cannabis in the treatment of PTSD and concluded that no published evidence of sufficient quality exists in the medical literature to support the practice. So consequently, they also do not endorse medical cannabis for the treatment of PTSD at this time, as further study is needed. The American Society of Addiction Medicine is the society for physicians who specialize in addiction. They say that medical cannabis should be rescheduled from level 1, that products should be subject to FDA review and approval, and that healthcare professionals who recommend non-FDA approved medical cannabis should be required to complete specific training with an emphasis on risk mitigation and the prevention, diagnosis, and management of cannabis use disorder or other substance use disorders. And such training should be evidence-based and should be informed by high standards of medical professionalism. They recommend a cautious approach to medical cannabis that involves a bona fide patient-clinician relationship, appropriate evaluation and follow-up, using a similar approach as with other potentially addictive medications, and discontinuing treatment if there's evidence of any harm. They state that the evidence should suggest the potential benefits for using medical cannabis outweigh the potential harms if indeed it is going to be used medicinally. They further advise against using medical cannabis for pregnant persons, and they state that physicians should recommend cannabis with great caution, if at all, for those with substance use disorders or psychiatric disorders, or to children and adolescents. They think that physicians should screen all patients for substance use disorders and refer them to treatment as appropriate, and that medical cannabis should not be recommended for clients with opioid use disorders, and that regulation should be overseen by departments of health and not driven by legislators or public referenda. that non-FDA approved cannabis recommended by clinicians should be reported to prescription drug monitoring programs, which should be checked by clinicians before recommending cannabis. That potency should be determined and clearly displayed on labels, and that clinicians should consider the THC to CBD ratio of the products they're recommending. Clinicians should discourage combustion or vaporization of cannabis. And finally, legislation and regulation should support quality research in this area. NADAC is the Association for Addictions Professionals. They do not currently support the use of cannabis as medicine or for recreational purposes. They strongly encourage research and evidence-based and scientifically supported policy changes pertaining to medicinal use of cannabis. They think that medical cannabis should be subjected to FDA research and the consideration process. And they state that a panel of neuro-researchers, addiction-certified physicians, prevention and treatment experts should be established by federal agencies to provide policy recommendations on cannabis legalization, medicinal and recreational use. That's an awful lot of information that I rapidly threw at you, so I'd like to offer a brief summary of all the positions of medical and psychological associations that we just reviewed. The positions of these associations on medical cannabis can be summarized thusly. Cannabis is a public health risk, and patients and providers should be educated on these risks. There's limited or at least mixed evidence of efficacy of medical cannabis. Additional research is warranted. Decriminalization is supported, and providers should be cautious about recommending medical cannabis. Safer alternatives should be utilized, and medical cannabis should generally be avoided for youth, individuals with substance use disorders, pregnant individuals, and for the treatment of mental disorders. Now, what associations do not have any official positions on medical cannabis? Well, they're on this slide. They include the American Association of Marriage and Family Therapy. They include the American Counseling Association, the American Mental Health Counselors Association, the American Psychological Association, and the National Association of Social Workers. Why don't any of these organizations have a position statement? Well, I think it's because none of these organizations are specifically catered to physicians or to addictions professionals. And so really the issue of medical cannabis might be thought of as not being as much within their scope of practice. And therefore, I think it's pretty appropriate that they don't have an official position on this issue. I've got another question for you. Given everything that you've heard thus far, do you think that medical cannabis should be prescribed or recommended for psychiatric and or substance use disorders? What do you think about that? The American Psychiatric Association published guidelines for the treatment of patients presenting with substance use disorders, and in those guidelines they state that whenever possible, medications with low abuse potential and relative safety and overdose should be selected for the treatment of patients with a co-occurring substance use disorder. So in other words, I think they're saying, let's avoid addictive medications when possible. The American Society of Addiction Medicine reports that healthcare professionals should recommend cannabis with great caution, if at all, to those with substance use disorders or psychiatric disorders, and that healthcare professionals should screen all patients for cannabis and other substance use disorders and refer to treatment as appropriate before recommending cannabis use for medicinal purposes. As we have already discovered, the American Psychiatric Association reports that there's no current evidence that cannabis is in any way beneficial for the treatment of any psychiatric disorder, including PTSD, and that they oppose the use of medical cannabis for psychiatric conditions. So it's pretty clear what those authoritative associations think about this question. Now, what do meta-analyses about medical cannabis for psychiatric disorders conclude? Well, anyone can go to Google Scholar, that's scholar.google.com, which is a way of restricting your Google search results to resources that are published in academic journals. And you could type a phrase such as meta-analysis, medical cannabis, psychiatric disorders, and you can start sifting through some of the evidence for yourself. But I think what you'll generally find is that meta-analyses do not look very promising for the use of medical cannabis for psychiatric disorders. Here are a few examples. McKee and researchers in 2021, this review finds limited evidence for the effectiveness of CBPs to acutely treat a narrow range of psychiatric symptoms. We report no evidence supporting the mid to long range effectiveness of any currently available cannabis-based product. In general, the quality of the evidence was assessed as low to moderate. Hill and researchers in 2021, as cannabinoids became more available, the need for an evidence base adequately evaluating their safety and efficacy is increasingly important. There's considerable evidence that cannabinoids have a potential for harm in vulnerable populations such as adolescents and those with psychotic disorders. The current evidence base is insufficient to support the prescription of cannabinoids for the treatment of psychiatric disorders. Lees and colleagues in 2021, clinical trials and laboratory studies provide evidence of anxiolytic effects of CBD in healthy volunteers and clinical populations, although current evidence is insufficient to support CBD as a first-line treatment. The evidence regarding the use of THC-dominant products for anxiety is ambiguous, with exacerbation of anxiety in some individuals and relief in others. Caution is required, as THC can impair driving and cognitive function. Despite the lack of robust supportive evidence, prescription of medicinal cannabis products for anxiety is increasing rapidly, while illicit cannabis is widely used in the community to self-medicate anxiety. Medical practitioners should carefully consider potential risks and benefits when prescribing medical cannabis for anxiety disorders and should start low and go slow. One of the reasons why medical authorities are so cautious about recommending THC for mental disorders involves genetics. Remember how we talked about how THC from cannabis can trigger psychotic and manic symptoms among people with certain genetic vulnerabilities? Well, what are those vulnerabilities? Well, there are two genes associated with an increased susceptibility to cannabis-induced psychotic disorders. Those two genes are the AKT1 gene located on chromosome 14q32 and COMT. Now, I don't know about you, but no one ever gave me a manual of all of my genes from birth and told me what things I should avoid because of it. So the issue is that many of our patients would not know whether they are particularly susceptible to developing psychotic disorders or bipolar disorders, perhaps triggered by their cannabis use. So it's important for us to screen for the possibility that they could have those vulnerabilities, such as by exploring their genetic family history of evidence of psychosis or mania and hypomania. For many years during live trainings on medical cannabis, I've been asking therapists to talk about how they think medical THC might affect psychotherapy. So in other words, if you have a psychotherapy client and they're using medical cannabis, how could that impact their sessions with you? And therapists often talk about, or some will talk about, how being mildly sedated might help open a patient up for a therapeutic experience, or it might reduce symptoms enough for them to benefit from therapy. But on the other hand, short-term memory impairment resulting from THC use may reduce the efficacy of psychotherapy, which relies very heavily on consolidation of the memory of the psychotherapeutic encounter. There's also a legal and ethical question of whether clients can lawfully consent to treatment while they're in an impaired state. And the use of medical cannabis might interfere with exposure-based approaches, because exposure-based therapies require patients to not be sedated by any kind of a central nervous system depressant. Ideally, the patient is participating in the anxiety-provoking behavior repeatedly and for a sustained period of time until their anxiety reduces, because the brain is incapable of keeping us in a suspended state of anxiety indefinitely. So eventually the anxiety level will come down, and when that happens and the patient has that experience of being okay even though they're doing the thing that's anxiety provoking, that's where we seem to get recovery from an anxiety or stress-related disorder or a phobia, for example. And so if they're sedated by medical cannabis, it seems to interfere with that process, much like if they were intoxicated with alcohol or they were under the influence of a benzodiazepine or some other central nervous system depressant. And also the use of medical cannabis might actually reinforce dysfunctional core beliefs, like I need this in order to function, or I can't handle life without cannabis. It might also reduce motivation to address the root causes of some of their conditions. Because let's say that, for example, somebody struggles with chronic insomnia and they figure out that if they use medical THC, they can fall asleep pretty rapidly. In 80% of cases of insomnia, the causes are thoughts and behaviors. And so if we're just medicating with a chemical, then are we going to be motivated to get to the underlying thoughts and behaviors that are the root cause of insomnia in that case? That raises a great question, and it's why the American Academy of Physicians recommends cognitive behavioral therapy for insomnia as the front line of treatment for insomnia, because we'll get the most effect for the widest number or range of patients by using that approach instead of an approach like medical cannabis. Now, at the root of this debate, I think, is the paradigms of recovery versus harm reduction. I think that this age-old debate factors into the debate on the use of medical cannabis. Let's briefly compare and contrast these two perspectives. Recovery is defined by the Substance Abuse and Mental Health Services Administration, or SAMHSA, as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Conversely, SAMHSA defines harm reduction as an evidence-based approach that's critical to engaging with people who use drugs and equipping them with life-saving tools and information to create positive change in their lives and potentially save their lives. So in other words, recovery, I would view it as being a kind of a higher order standard. Our goal is to help people reach their fullest potential in recovery. But in harm reduction, we're just trying to reduce how much harm is happening to them as much as we can, kind of reduce the impact of adverse consequences in their life. And so some people would argue that medical cannabis could be a good harm reduction technique, because maybe, for example, a patient who will stop using opioids as painkillers and start using medical cannabis as painkillers is going to be reducing their risk. They won't have to worry about fatal overdoses, for example, and they might fare better on medical cannabis than they had on opioids. And that, in that sense, could be great harm reduction. But from a recovery paradigm, we'd really like them to reach their full potential and not need either potentially addictive substance or have a problem with either potentially addictive substance. So I think harm reduction certainly has a place in society, and I do harm reduction work with clients. But I'm more passionate about recovery because ideally I'd like to see people reach their full potential, of course. And it's okay to sort of have that bias as long as a clinician is also willing to meet clients where they're at. Some clients are not going to be willing or ready for the recovery approach. And I think sometimes we need to then roll up our harm reduction sleeves and work with them where they're at. But we're going to talk some more about that later. Let's just go over a few real case examples and kind of ponder whether recovery or harm reduction seems like the appropriate approach for each of these clients. Now, I have, of course, changed facts related to these cases to better protect the privacy and confidentiality of the patients involved. Ron is a 28-year-old paramedic. He completed residential substance abuse treatment as a minor due to polysubstance dependence, which was a DSM-4 diagnosis for people that have meet the criteria for substance dependence for several different substances. He experienced a series of deaths at work. He endorsed symptoms sufficient for the diagnosis of PTSD, and he'd been removed from active duty and placed on light duty due to angry outbursts and panic attacks at work. He's drinking approximately 20 servings of alcohol a day, coupled with daily use of medical THC. He believes that substances are the only things that help his anxiety or his panic. He wants to return to active duty. What do you think for this client? Do you think we ought to use a recovery approach or a harm reduction approach? When I ask this question during live trainings, most clinicians say that they think we ought to use a recovery approach with Ron, and they give a variety of reasons for that. They talk about how he's in a safety-sensitive occupation where he really shouldn't be using any medical cannabis at all, and he seems to have very severe addictive tendencies, and medical cannabis could be very problematic for him. Well, that is the approach that we used with Ron. We used a recovery approach. Now, I do want to point something interesting out. He went 2 days without alcohol and cannabis, and his panic attacks reduced to 5 to 6 panic attacks a day. With 7 days of abstinence from both alcohol and cannabis, he was down to 1 to 2 panic attacks a day. With 13 days of abstinence, he was down to 1 panic attack in a week. And within 17 days of abstinence, 1 panic attack, but with a milder severity than the previous week. After 20 days of abstinence, he drank heavily on a weekend and immediately started experiencing panic attacks daily again, and was therefore referred to residential treatment because he was struggling to maintain abstinence on an outpatient basis. And I think what this case illustrates is that although Ron believed that alcohol and cannabis were the only means to reduce his panic, it's clear that when he abstained from alcohol and cannabis, he stopped experiencing panic attacks. They reduced over time and then stopped altogether. And I see this a lot with people who are using addictive substances to try and self-medicate against their panic and anxiety. That if they stop using it altogether, their panic and anxiety will often improve significantly, especially if they're learning alternative coping strategies to address those issues. Let's look here at a second example. Recovery or harm reduction. Kayla is a 30-year-old white female. She has a history of residential substance abuse treatment as an adolescent. She was diagnosed with severe opioid use disorder and has no driver's license due to her DUIs, and she does not drink. She doesn't drive at all. She has a co-occurring generalized anxiety disorder. She's had multiple failed attempts at recovery and abstinence approaches despite a sincere and genuine effort. She has a prescription of daily clonazepam, which is a benzodiazepine, medical THC, and Suboxone. She works from home, so she doesn't have to drive to work. She does not feel ready to come off of her current regimen of medication. She's in a fulfilling long-term relationship with a live-in boyfriend. She's doing well at work, getting promotions and being evaluated very positively there. She is voluntarily seeking supportive therapy. What do you think about Kayla? Do you think we ought to use a recovery or harm reduction approach? Well, the approach that I used with Kayla was harm reduction. Why? Because there's less immediate risk of significant or life-altering problems in the current situation that she's in. She seems to be functioning okay-ish given the circumstances. She's had a significant history of the recovery approach not working well for her, and frankly, she's not ready or willing for the recovery approach at this time and is trying to seek help with some supportive therapy. So I elected to honor her autonomy and her decision and work with her where she was at. And of course, some seeds can be planted for her to eventually potentially pick up on the recovery paradigm, but for now I met her where she was at. In the professional literature, researchers and clinicians have voiced concerns about the practices of cannabis dispensaries, where patients go to obtain their medical cannabis, and specialty clinics, which are clinics that advertise a specialty in medical cannabis, where patients go to get a physician's recommendation for cannabis. Some of those concerns include inadequate scientific knowledge of medical cannabis, a lack of educational and training standards, lack of coordination of care. For example, these physicians are often not communicating with other healthcare providers working with the patient to get some helpful background information or a more full and robust medical history. Complexity and inconsistency of dosing practices and self-dosing, which involves the patient determining, what they use, how much, when, and how often. Recreational use disguised as medicinal or therapeutic use. A lack of unbiased clinical guidelines, and misleading advertising and promotion, some of which exaggerate the efficacy of medical cannabis. In the professional literature, we can find dosing guidelines published by researchers. Let's talk about that for a few minutes. Many years ago, I had the honor of training with Dr. Gregory Smith, a physician who wrote what appears to be one of the first published textbooks on medical cannabis, entitled Medical Cannabis: What Clinicians Need to Know and Why, Basic Science and Clinical Applications. Dr. Smith helped to design many of the medical cannabis products that were being sold at the time. He taught us that if a patient is using a dose of 10 milligrams of THC or greater, then they're probably over-medicated, as most conditions should respond to doses of 10 milligrams of THC or less. Additionally, most conditions respond to CBD to THC ratios of 1 or more parts CBD to 1 part THC. And recreational cannabis, on the other hand, usually consisted of CBD to THC ratios that looked more like 1 part CBD to 15 or more parts THC. He also said that if your patient feels high, buzzed, or euphoric, then they're probably over-medicated, as medical cannabis is intended to help people to function normally, not to produce a high. Researchers use 5 milligrams of THC as a standard unit of THC. It's enough to produce a mild intoxication among infrequent users. 5 to 10 milligrams is conceptualized as lower potency products, and more than 10 milligrams as higher potency products. Individual oral doses of 10 to 20 milligrams of THC are sufficient to achieve psychotropic effects. 30 to 40 milligrams should produce marked intoxication with an onset 0.5 to more than 1 hour after ingestion, with a peak of 3 to 4 hours after stacking oral doses. Yet, in an online review of products sold in Florida clinics, I saw THC doses of 10 milligrams to 600 milligrams. So 10 milligrams was on the lower end with products that I was seeing. And the CBD to THC ratios were more like 1 part CBD to 20 parts THC, up to 1 part CBD to 826 parts THC, with most ranging between 1 part CBD, 20 parts THC, and 1 part CBD, 60 parts THC. there seems to be a substantial difference between what's being sold in the dispensaries and what experts would say is medically appropriate. Bhaskar and colleagues published a Delphi study that gives us a sense of consensus of physicians who prescribe medical cannabis in terms of what they view as appropriate dosing guidelines. Dosing guidelines for neuropathic, inflammatory, nociplastic, and mixed pain was explored in this study. There was a consensus of 20 global experts in 9 countries. They developed 3 different treatment protocols: a general protocol, a conservative protocol, and a rapid protocol. Let's talk about the general protocol, which is kind of the default protocol. This protocol involves starting patients with 5 milligrams of CBD twice a day and no THC at all. Physicians would then titrate by 10 milligrams every 2 to 3 days until the patient reaches their goals, never to exceed 40 milligrams a day. At 40 milligrams a day of CBD, without the patient achieving their goals, then the physician may consider adding THC 2.5 milligrams a day and then titrate by 2.5 milligrams every 2 to 7 days until the patients achieve their goals or they've reached a maximum dosage of 40 milligrams a day. But quite honestly, clients that I work with tend to use a lot more than that and on a daily basis. In another guideline published by McCollum and colleagues in 2021, physicians would consider initiating CBD instead of THC for these populations: older adults, patients that are less than 25 years of age, patients with a history of mental health and with heart conditions, with personal or strong family history of psychosis or bipolar disorder, with concurrent mood or anxiety disorders, with severe liver disease, with other conditions or medication regimens associated with sedation or cognitive impairment that may compound the effects of THC. They'd also consider CBD instead of THC for individuals who work in safety-sensitive occupations, for individuals who use a variety of substances, and for those who are at risk for pharmacodynamic drug interactions. So in other words, these are individuals for whom medical THC should be avoided, but unfortunately I see a lot of people who are using medical THC who fit into these categories. McCollum and colleagues then go on to describe some dosing guidelines for those whom THC might be used. Their first step involves starting with 5 milligrams of CBD oil twice a day. Step 2 is to titrate the dose by 5 milligrams of CBD every 2 to 3 days. Step 3 might involve bringing in THC. If CBD alone is not reaching treatment goals, then clinicians can consider adding THC after an assessment of the benefits versus the risks. The recommendation would be to start the dose at 1 to 2.5 milligrams THC at bedtime, and then to titrate by 1 to 2.5 milligrams of THC every 2 to 7 days. And if daytime THC is needed, then start the dose at 1 milligram of THC, titrate by 1 to 2.5 milligrams of THC every 2 to 7 days. Step 4 would involve doses above 40 milligrams a day of THC, rarely ever being required. If reached, clinicians should reassess the risk-benefit ratio for the patient. The problem is that the clients I work with who use medical cannabis are just self-dosing. They don't really know what dosing guidelines are or what they should be doing, so they just kind of do what they want to do. Here I'll offer a case example of some concerns with specialty clinics and dispensaries. This was related to a forensic evaluation that I conducted, though I've changed the details substantially to better protect the privacy and confidentiality of those involved. But this is a 19-year-old client referred for a forensic mental health evaluation related to a cyberstalking charge. He struggled with depressed mood, a sense of loneliness, isolation, lack of self-worth, and personal inadequacy. His father suddenly started exhibiting mania and psychotic symptoms in his 50s, resulting in multiple hospitalizations, loss of job, having spent through family savings, and a separation with a pending divorce. His paternal uncle had a very similar experience. In high school, the client became obsessed with a female friend and asked her out, was rejected, and then discovered that that female friend was seeing another boy. He obtained a medical marijuana card and was using high doses of THC several times a day, every day at the time of the evaluation. He began exhibiting disorganized thinking, constricted affect, and delusions. He started engaging in stalking behaviors fueled by paranoid thoughts and a sense of destiny. He works in pizza delivery, and he rejects psychotherapy because he perceives that cannabis is the easiest and most effective route to addressing his depression and anxiety. And one of the reasons I think it's important to note that the client works in pizza delivery is that his job involves driving, but he's using very high doses of THC every day, including before he goes to work. There are plenty of concerns with this case, but one obvious concern is that there's clearly a family history of developing psychosis and mania when using THC, raising the question of why he was ever recommended by a physician to use medical THC. Here I've pasted a screenshot of the website of that specialty clinic. While detracting anything that would positively identify that clinic, my intention here is not to publicly ridicule an organization, instead it's to expand awareness. I see several things on their website that concern me. First, notice that the clinic advertises that obtaining your medical card recommendation should be as easy as 1, 2, 3. Should it really be that easy? Is that something that should be touted as beneficial? Do we already have some reason to question the quality of assessments performed at the clinic? Second, note that it says that you can complete a brief online questionnaire and immediately find out if your condition may qualify you to receive your medical card. Immediately? At the top of the page, we see that there's a no-risk guarantee. If you fail to qualify, then you're charged nothing. Doesn't this sound like the practice of a clinic that could be biased toward making sure that the patient gets a medical marijuana recommendation? After all, they would have to do so in order to generate any money and stay in business. Good news for them, I guess, is that in all the cases I worked with in which a client went to this clinic, none of them were ever turned down, regardless of what conditions they claimed to have, raising a question in my mind of how often they really conclude that someone is not a good fit for medical cannabis. When I obtained the patient's records from the clinic, I could not find any specific diagnosis in the file, nor could I find any specific symptoms supporting a diagnosis. I could not tell what led the physician to conclude that the patient was appropriate for medical cannabis. I could not see any evidence that the patient had been screened for a family history of psychosis or mania, and there certainly was no evidence that the clinic communicated with the patient's primary physician to obtain additional information. All I could see was a list of conditions and checkboxes next to each one. They were all unchecked except one, a line that read PTSD, and then in parentheses, anxiety, depression, insomnia, stress, and ADHD. However, when I evaluated the patient, which took several hours and included a thorough clinical interview, the administration of several psychological tests, reviews of medical records, and interviews with others who had close contact with the patient, I found no evidence that the patient had any of these conditions. The only exception I could offer is stress, but every human being has some stress. Stress is a normal part of life and is necessary for human survival. Just because someone experiences stress doesn't mean that a medical condition exists and that they need to be medicated. There are, of course, trauma and stress-related disorders, but this patient did not meet criteria for any such disorders. To this day, I don't know why medical cannabis was recommended. Even if the patient had PTSD, a depressive or anxiety disorder, or ADHD, remember that we already learned that the existing evidence would not support medical cannabis as an effective treatment for those conditions. And the American Psychiatric Association does not endorse medical cannabis for treating such disorders. Lastly, remember that many standards discourage recommending medical cannabis for young adults, such as a 19-year-old, because of the tendency for cannabis to produce more substantial cognitive effects when the brain is still developing. So question here is raised. If this patient had been thoroughly evaluated, would his family history of psychosis and mania correlated with THC use been discovered? If he hadn't been recommended for medical THC, would he never have developed the life-altering chronic and severe mental illness that he ended up developing? Here we see the safety-focused framework that McCullough and colleagues published. Using this model, the physician would have screened for precautions and contraindications for cannabis use, and if you saw that list a few slides ago that included such contraindications, a few of them would have applied to this patient. Second, the physician would screen for drug interactions. Third, they would consider the safety of the route of cannabis administration. Fourth, they'd consider the safety of chemovars or strains of cannabis. Fifth, they'd initiate a low-dose, slow titration strategy, and they'd set a schedule for monitoring the patient on an ongoing basis. I really wish more physicians at specialty clinics adhered to a protocol like this. I assume that some do, but I can't recall encountering a case myself. McCollum and colleagues also published a list of considerations, precautions, relative contraindications, and stronger contraindications in their research. Let's take a look at some of these variables here. Let's start with considerations. I think that physicians should consider, really second guess whether cannabis would be appropriate for individuals who are immunocompromised, who have chronic kidney disease, older adults, patients with concurrent medical conditions, polypharmacy patients, and those with potential drug interactions. Moving up that hierarchy, we get to precautions. They should be cautious about individuals with concurrent mood or anxiety disorders, who have risk factors for cardiovascular disease, who use tobacco or e-cigarettes, who have severe liver dysfunction disease, and who use medications associated with sedation or cognitive impairment, or who drive or work in safety-sensitive occupations. Cannabis should be relatively contraindicated for people under 25 years of age, or who currently or in the past met criteria for a cannabis use disorder or another substance use disorder. And medical cannabis should be contraindicated for people with unstable cardiovascular disease, respiratory disease if smoking cannabis, have a personal or strong family history of psychosis or bipolar, and are pregnant or planning on becoming pregnant or breastfeeding. I am very much aware that there are individuals who use medical cannabis who have very legitimate medical needs for doing so, and they use medical cannabis with relative safety, and it doesn't seem to be creating any kind of a problem for them. But on the other hand, a growing body of research suggests that most Americans who have obtained medical cannabis cards thus far are not necessarily people who have legitimate medicinal needs for cannabis. They tend to be recreational users, heavy smokers, or individuals who are likely to have cannabis use disorders instead of those who have legitimate medical needs for cannabis. So this raises a very interesting and important question. Given that medical and recreational users, as Roy Burns stated, had many more similarities than differences, and the differences were small, suggesting that only a few medical users were likely targeting medical conditions, how do we differentiate between those who have a legitimate medical need for the use of cannabis and those who maybe instead have an addictive disorder, have a cannabis use disorder? That's what we're going to focus on next. Let's start with identifying some risk factors for developing cannabis use disorders in the professional literature. A cannabis use disorder is an addictive disorder involving a maladaptive pattern of cannabis use leading to clinically significant impairment or distress. First, in their report that we've already referenced a few times during this recording, the National Academies of Sciences, Engineering, and Medicine identified the following risk factors. Now, it's important to note that none of these risk factors prove that a person will develop a cannabis use disorder. They're just associated with a greater likelihood of developing one. It's also important to note that one would expect that a person with several of these risk factors would probably be more likely to develop the disorder than someone who has fewer risk factors. NASEM's identified risk factors include being male and smoking cigarettes, earlier age of initiation of cannabis use, greater frequency of cannabis use, a diagnosis of major depressive disorder, use of combinations of drugs, oppositional behaviors during adolescence, a younger age of first use of alcohol, nicotine use during adolescence, substance use by parents of adolescents, antisocial behaviors during adolescence, childhood sexual abuse, history of psychiatric treatment, and increased severity of post-traumatic stress disorder symptoms. All of these factors, according to NASEM, increase a person's risk for developing a cannabis use disorder if they use cannabis. Douglas and colleagues identified these risk factors for daily cannabis use among young adults. In other words, young adults with these characteristics are more likely to use cannabis regularly, specifically daily. They include older age, male sex, higher levels of family stress and other stress, use of alcohol, cigarettes, and other tobacco products, parents, siblings, and friends who smoke cigarettes, higher body mass index, higher impulsivity and novelty seeking, and lower self-esteem. All of these variables increase the odds of daily cannabis use among young adults. In 2022, Rajapaksha and colleagues published these 7 risk factors for developing cannabis use disorder based on their research. Those include younger age, lower level of enjoyment from initial smoking, a higher score on the Impulsive Sensation Seeking Scale questionnaire, a higher score on the Cognitive Instability Factor of the Barrett Impulsivity Scale questionnaire, and higher scores on neuroticism, meaning being more prone to experience negative emotions, and the openness scales, but lower scores on the conscientiousness scales and the neuroticism, extroversion, and openness inventory. That same year, Lon and colleagues published research concluding that adolescents were over 3 times more vulnerable to develop a cannabis addiction than adults, but they were not at increased risk of other mental health problems related to the drug. At the beginning of this video, I mentioned that I created a decision matrix intended to help clinicians apply practice guidelines related to medical cannabis when patients present with medical cannabis use in mental health and substance use treatment settings. We're about to explore that tool, but before we do, I'd like to offer this disclaimer. The decision matrix is based on guidelines published by authoritative professional organizations such as the American Society of Addiction Medicine, who, in turn, based their guidelines on a comprehensive research review. However, the matrix itself has not been validated in peer-reviewed research. Nonetheless, it provides a logical and structured model to aid counselors in decision-making processes that mirror existing practice guidelines while still offering flexibility based on clinical judgment on a case-by-case basis. The matrix has been published in a couple of formats. The format you see on this screen was published in The Advocate magazine, the official magazine of the American Mental Health Counselors Association. Another version was published in the American Counseling Association's Counseling Today. Here's a brief overview of the tool. When a client presents with their medical marijuana card, the first task for the clinician is to conduct a substance use evaluation if one has not already been completed. The clinician will need to answer the question of whether the patient has one or more substance use disorders. So then, before we go any further, let's talk about diagnosing substance use disorders. We'll begin by exploring the diagnostic criteria of a cannabis use disorder as illustrated in the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, the most current version of which at the time of this recording is the DSM-5-TR. The DSM-5-TR defines cannabis use disorder as a problematic pattern of cannabis use leading to clinically significant impairment or distress is manifested by at least 2 of the following occurring within the same 12-month period. Now that's a mouthful already, but this would mean that a person has a pattern of using cannabis. This isn't an isolated event or one particular adverse experience involving cannabis. The individual has to have been repeatedly using cannabis. And that pattern of use is problematic. How do we know if it's problematic? Well, we have to decide whether it leads to clinically significant impairment or distress. Impairment means that the substance use has a negative effect on the person's ability to function. And distress is more about the internal state of that individual. How do we decide if the person is experiencing significant impairment or distress? Well, in the case of substance use disorders, we're going to look for at least 2 of the following 11 symptoms occurring in the same 12-month period. The first symptom is that cannabis is often taken in larger amounts or over a longer period than was intended. This could apply if, for example, an individual intends to only smoke or vape a certain amount and then they go beyond the limit that they've set for themselves, and if this seems to be a pattern for them. Or maybe they intend to just smoke for a little bit of time, but they end up spending a lot more time smoking or vaping than they planned on. The second is that there's a persistent desire or unsuccessful efforts to cut down or control cannabis use. So maybe there's been this kind of voice within the person's mind saying, this is not good, I should be doing a lot less of this, I really ought to. And they've wanted to do something about it for a while, but they haven't actually done anything about it yet. Or maybe they've tried to quit or just cut back, but they find themselves unsuccessful and keep returning back to a heavier amount of use. Third, a great deal of time is spent in activities necessary to obtain cannabis, use it, or recover from its effects. It's absorbing an awful lot of their time, and presumably that would make it difficult for them to have as much time for other important things in life. There's really no specific amount of time that constitutes meeting this criterion, so it's really up to the clinician's judgment. Some people would say if you're spending more than a couple hours a day doing something, then using a substance in particular, then it's probably absorbing a great deal of time. But I think this has to be decided on a case-by-case basis, based in part on what the individual's lifestyle is like and whether the amount of time that they're spending using cannabis is problematic given how many other important things they really need to be doing with their time. The fourth symptom is craving. Craving isn't just, I'd kind of like to do something. It's a strong desire or urge to use cannabis. The fifth symptom is recurrent cannabis use resulting in a failure to fulfill major role obligations at work, school, or home. For example, I've worked with clients who can acknowledge that if they come home from school and they vape or smoke cannabis, then even if they intended to do their schoolwork or to study or to work on a paper, they're a lot less likely to do so, and they can acknowledge that there's some kind of adverse effect of their cannabis use on their schoolwork. And in that case, we could say that their cannabis use is resulting in a failure to fulfill major role obligations at school. At home, this might come in the form of neglecting household chores or not being as attentive a parent, or for that matter, child abuse and neglect related to an individual being high too frequently or when they're supposed to be taking care of children. Another example could be that a person is losing jobs or they're not going out on job interviews as much because they smoke or vape and then kind of feel less like wanting to go out and do a job interview. But those are just some examples from real cases I've worked with over the years. The sixth symptom is continued cannabis use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of cannabis. This could, for example, relate to people that get into arguments with a significant other about their heavy cannabis use. I had a friend who he would make promises and commitments to family members or friends to show up at an event, for example, and then not show up because he got high. And in that case, his substance use seemed to be creating some problems in his relationships and friendships with other people. Some couples argue about how much money is being spent on cannabis because that money really should have been spent on some other important household expenses. Some people argue that their partner is less available to them or is so often in an impaired state that it doesn't feel like they're really in a relationship with the real person anymore. Had a colleague who divorced a spouse for that reason because he became very heavily addicted to marijuana and over time was just less available and less engaged in the relationship and had a difficult time with goal-oriented activity. And she kind of realized she really didn't want to be with somebody if their future was going to look like that. The seventh symptom is important social, occupational, or recreational activities are given up or reduced because of cannabis use. I have a good friend that quit the football team, quit playing the drums in a band, quit going to church with his family, and all of those things that he quit that used to be important to him went to the wayside as cannabis use became heavy and regular, and essentially he wanted to spend his time smoking cannabis and focusing on that instead of participating in those important activities. The eighth symptom is recurrent cannabis use in situations in which it is physically hazardous. The most common way that this criterion would be met is by driving when under the influence of cannabis, which we've certainly talked about earlier, but there are plenty of other examples like operating heavy machinery when under the influence of cannabis, or for that matter, handling a firearm. I had a client one time who was a gun enthusiast, and he was high and showed a friend his new pistol, and he dutifully ejected the magazine and then handed the weapon to his friend and said, "Go ahead and pull it and get a sense of what the weight is on the trigger." And the friend did so, and the gun fired. And what happened was that in an impaired state, he forgot that he also needed to clear the chamber, make sure there wasn't a round in the chamber. A very simple mistake that he doesn't believe he would ever have made if he wasn't in an impaired state at the time that he was handling the firearm. Fortunately, no one got hurt from that incident, but it was certainly a sobering wake-up call for the client that told him that he needed to make some changes in his life, and is an example of this symptom being met, especially if there were a pattern of different things that he were doing that could be examples of physically hazardous situations in which he's impaired. The next symptom is that cannabis use is continued despite knowledge of having a persistent or recurrent physical or psychological problem likely to have been caused or exacerbated by cannabis. For example, I had a client whose gastroenterologist advised him to completely abstain from cannabis because it was clearly worsening his gastrointestinal symptoms. And he knew that was the case, but he didn't stop using cannabis and continued having those GI problems for quite a while. So that would be an example of the symptom being met. Another example can be more psychological. For example, in the first season of Celebrity Rehab, used to be on VH1, there is a celebrity who talks about how she doesn't go out on auditions even though she's been without a job and has been an actor for many years. And she smokes cannabis to try and feel like going out on an audition, but if she smokes, she's not going to go, no matter what, because she says she gets lazy and lethargic when she smokes, and then she doesn't feel like doing anything. And that could be described as amotivational syndrome, which could involve, it has to do with there being CB1 receptors in the hypothalamus that regulates, among other things, motivation, drive, energy, and ambition. And she's aware of that connection, but she continues to use cannabis anyway. The 10th symptom is tolerance. Tolerance can mean that the individual needs more THC to get the same effect or the same high they used to get from less. Or it could mean that they're using the same amount of THC that they've been using, but they're getting less of a high or effect from it over time as their system habituates to the presence of THC and starts turning down or modulating other neurotransmitter levels to try and accommodate it and feel as normal as possible under the influence of it. The 11th and final symptom is withdrawal. But To really determine whether somebody could be experiencing cannabis withdrawal, we have to look at the criteria for a separate disorder called cannabis withdrawal, which we're going to do in just a moment. But one thing I think is very important to point out is that of these 11 symptoms, the client only has to have 2 in the same 12-month period. They certainly don't need all 11 symptoms, even though I've worked with people who do meet all 11 symptoms in the same 12-month period. Now, if the client has had at least 2 of those symptoms in the same 12-month period, then the next question is, are they in remission or not? Early remission means that the client has gone for at least 3 months, but less than 12 months, without experiencing any of those 11 symptoms, with the possible exception of craving. But if the client has gone for 12 or more months without meeting any of those symptoms, then we would call that sustained remission. So let's say that you had a client who met criteria for a cannabis use disorder that was moderate, and they've gone for 13 months without experiencing any symptoms other than maybe craving. Then we would say that's a cannabis use disorder, moderate in severity, in sustained remission. But next, we also have to determine whether they are in a controlled environment or not, if they're in remission. So a controlled environment is an environment where somebody has less access to cannabis. That could be jail or prison, or it could be a residential program or a halfway house, for example. If somebody had gone for 4 months without experiencing any of those 11 symptoms of a cannabis use disorder, with the exception of craving, and they were in a long-term intensive residential drug treatment program, then we would say a cannabis use disorder, and we would say that they're in early remission, but they're in a controlled environment, and all of that would be part of the diagnosis. Again, if they have at least 2 symptoms, 2 or 3 symptoms in the last 12 months of meeting symptoms, then it would be a mild cannabis use disorder. 4 to 5 symptoms is moderate, and 6 or more of those 11 would be a severe cannabis use disorder. I mentioned that in order to determine whether the client has met the 11th symptom, which is withdrawal, we have to be familiar with the diagnostic criteria of cannabis withdrawal. So cannabis withdrawal is defined as cessation of cannabis use that's been heavy and prolonged. Typically, that means that the client's been using cannabis daily or almost daily, and they've been using for at least a few months. If they suddenly stop using cannabis or reduce their use significantly, then the next question is, do they experience 3 or more of these signs and symptoms within 1 week of that cessation or reduction of use? So what are those 7 signs and symptoms of which they must have at least 3? They include irritability, anger, or aggression, nervousness or anxiety, sleep difficulties such as insomnia and disturbing dreams. Very common for me to hear from heavy cannabis users that when they stop using, they suddenly experience very strange, vivid, and intense, often troubling dreams, and that's partially because they've been spending less time in REM stage and sleep while using cannabis, and so now that they are experiencing normal REM sleep again, there's a period of time when dreams seem particularly salient, and that can be a troubling experience for some people. Decreased appetite or weight loss is number 4. We also have restlessness, depressed mood, and at least one of the following physical symptoms causing significant discomfort: abdominal pain, shakiness and tremors, sweating, fever, chills, or headaches. Next, we have to determine that the signs or symptoms in criterion B that we just reviewed cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So does it have a negative effect on their ability to function socially or in relationships or with their work tasks or in other important areas of their life? And finally, those signs or symptoms have to be determined to not be attributable to some other medical condition or are not better explained by some other mental disorder, including intoxication or withdrawal from another substance. How prevalent is cannabis use disorder? Well, let's focus on 12-month prevalence rates. In the past 12 months, we would estimate that approximately 2.7 to 3.1% of youth ages 12 to 17 meet the criteria for a cannabis use disorder. Among adults age 18 and older, that number would be 1.5 to 2.9%. Among cannabis users, which we will define as an individual who's used cannabis at least once in the past year, the prevalence rate is 20.4% for youth and 30.6% for adults. So in other words, roughly 30% of adults who've used cannabis even once, or at least once in the past 12 months, meet the criteria for a cannabis use disorder. The highest rates are among adults ages 18 to 29, 6.9%, and the lowest is among adults ages 45 years and older, 0.8%. The disorder is more prevalent among men, 3.5%, than among women, 1.7%, and more prevalent among boys, 3.4%, than among girls, 2.8%. There do seem to be some ethno-racial differences in prevalence of cannabis use disorder among adolescents 12 to 17 years of age, with Hispanic youth having the highest rates, followed second by white youth, third by African Americans, and then finally by other. There are also some ethno-racial differences among adults, with American Indians and Alaska Natives having the highest rates, followed by African Americans, Hispanics, whites, and Asians and Pacific Islanders. In the US and other high-income countries, rates of individuals seeking treatment for cannabis use disorders have been increasing since the 1990s, but only 7 to 8% of adults with cannabis use disorder receive treatment in the past year. So it is a condition for which people are dramatically undertreated. In the forensic and occupationally mandated evaluation arenas, practice guidelines encourage clinicians to use multiple sources of data for a thorough evaluation. Here are those 4 categories of data. The first is a thorough clinical interview in which the clinician asks the client questions to assess whether the 11 symptoms have been met. Problem is that many individuals participating in a substance use evaluation will not be forthcoming with information, or they may have a distorted perception of their substance use due to denial and other psychological defenses. So a clinical interview is not considered sufficient by itself. The second category is the use of tests and measures. An example of a great test is the SASI-4, which is the Substance Abuse Subtle Screening Inventory. This is a gold standard test because it includes validity and reliability scales to help get a sense of whether we can trust a client's self-report, to look for signs that they may be minimizing their substance use, or that they may be inconsistent when answering similar questions about their substance use. It also uses statistical norms to predict the probability of a substance use disorder even when a client denies having substance-related problems, and can give the evaluator some clues about that. Another example of an appropriate test might involve urine drug screening to supplement or corroborate a client's self-report about their recent substance use. A third category of data is records reviews. An evaluator might, for example, obtain a client's records from a hospital or from a primary care physician's office, or from a therapist who might have worked with the client before. Or they might even examine arrest records and see if there's substance-related arrests in a person's background. Can't tell you the number of times that I've pulled medical records for a client and discovered a great amount of evidence that they were continuing to use substances even though it was creating significant medical problems for them and had been advised by others to stop using, but during the clinical interview they denied whether any of those things were true. Or maybe during the interview they denied ever driving under the influence of a substance, but their DUI arrest history would suggest otherwise. The fourth category of data involves collateral interviews, and this is when the evaluator might interview other people, such as a client's roommate, spouse, or significant other, or a neighbor, or an employer, or a 12-step sponsor, or their therapist, The list goes on in terms of potential people who might be good to interview. I'm not saying for clinical evaluations versus forensic or occupationally mandated evaluations that all 4 of these data categories have to be used for every single client. In fact, that would actually be uncommon in my experience. But I do think that it would behoove evaluators to try and use more than one data source when they are assessing for substance use disorders. And I would think at least a clinical interview and the use of tests and measures would be helpful. Probably also records reviews if the client will consent to getting those records. Let's assume that you, the clinician, have conducted a thorough substance use evaluation, or maybe someone else whose work you trust has, and there's no evidence that the client meets diagnostic criteria for a cannabis use disorder. Additionally, let's say that there's no evidence that the client meets criteria for any substance use disorder, such as alcohol use disorder or opioid use disorder. What might you do then? Well, you'd next want to find out if the client wants to stop using medical cannabis. Maybe the answer to that is yes. Sometimes clients do want to stop using their medical cannabis and they're looking for help with that. So if yes, collaborate with their physicians to offer alternative treatment options to address the conditions for which cannabis is being used. You as a mental health professional can offer psychosocial interventions for those problems as a supplement to whatever medications the client's physician might be prescribing. So for example, maybe the client was taking medical cannabis to help them with their sleep. You might offer cognitive behavioral therapy for insomnia if that's within your practice. Or maybe the client was taking medical cannabis for anxiety, and you might offer cognitive behavioral therapy or acceptance and commitment therapy. Or maybe it was related to social anxiety, and you're going to provide exposure therapy to help the client with their social anxiety. Or maybe it was for PTSD, and you're going to provide narrative exposure therapy, or maybe EMDR, or some other kind of trauma-informed treatment or approach. But what if the client wants to continue using their medical cannabis, and again, you've concluded that they have no substance use disorder? Well, you ever heard the old saying, if it ain't broke, don't fix it? If there doesn't seem to be a problem, then there isn't a problem. So your work might be more supportive or preventative in different ways. You might consider educating the client on the potential risk for the future for their cannabis use. You might provide some psychosocial interventions that supplement their medication, their medical cannabis. You might monitor and screen periodically for evidence that the clinical picture is changing and maybe they are developing a problem with their cannabis use. You might also explore with the client what their end game is. So what do I mean by end game? Well, let's say that the client is taking their medical cannabis for sleep again. Well, there is some evidence that over time, the cannabis will have less helpful effect on their sleep, and they'll probably build a tolerance to it, and it'll take more cannabis to get the same effect they used to get from less, and this should be explained to the client. And then the question should be, what would you like it to look like 10 years from now or 3 years from now? Do you want eventually to get off of the medical cannabis, or do you want to continue using it indefinitely even though those potential risks exist down the road? And sometimes clients are very willing, even if they are going to continue using medical cannabis, to explore additional treatment options and start using those to see if they might be able to eventually titrate down from their medical cannabis and in the future no longer have to use it in order to still be able to function well in terms of whatever problem they were seeking the medical cannabis for to begin with. But what if, on the other hand, you feel confident that this client does have one or more substance use disorders? You've done a thorough evaluation and it seems pretty clear to you that they meet diagnostic criteria for one or more substance use disorders. Well, then there's a different approach recommended in the decision matrix. If the client does have one or more substance use disorders and they want to continue using medical cannabis, then the next question is, how severe is their substance use disorder, or are there substance use disorders? If the disorder is mild, then it's possible that a harm reduction approach might be a viable approach for the patient, and that could be explored. But if the substance use disorder is moderate to severe, then the likelihood that the client will be able to use medical cannabis indefinitely in the future without it becoming problematic for them, if it's not already problematic, becomes much lower. And so then an abstinence-based approach is preferable. But the next question becomes, do you have leverage or not? If you have leverage, you use it. So what is leverage? Leverage might mean that a client is being mandated to see you because they want to get something that requires successful completion of treatment. For example, the scenarios I talked about at the beginning of this video would apply. What if a client has lost custody of their children because of substance-related abuse or neglect, and they must complete treatment successfully in order to regain custody of their kids? Well, then you have leverage. Or what if a client lost their driver's license due to DUI offenses, and they must complete treatment successfully in order to regain their ability to drive? Well, then you also have leverage. Or maybe they have to complete treatment successfully to get off of probation, and they're not supposed to be using substances when they're on probation. Well, that would be another example of having leverage. If you have it, you use it, but you use it very respectfully. You coach it as being in the client's best interest as well as the interest of the public. And so we'll talk a little bit about how you use that leverage in a moment. But if you don't have leverage, maybe this is a client who's just seeing you because they just wanted to come in and get some help, and they use medical cannabis, they want to continue using it, but they do have a moderate to severe substance use disorder, you've got no leverage. Well, if that's the case, then you would meet the client where they're at. You would work with them where they're at, respecting their autonomy, and do the best job that you can. Remember, of course, that legal doesn't mean healthy. In other words, just because a client has a medical marijuana card and can therefore legally use medical cannabis doesn't mean that it's healthy for them to do so, appropriate for them to do so, or clinically in their best interest even. Alcohol is legal, but would you successfully discharge a client with a moderate to severe alcohol use disorder for mandated substance use treatment who never stopped drinking? How about a client with a severe addiction to opioids who never stopped taking legally prescribed oxycodone? Or how about a client addicted to Xanax or other benzodiazepines who was obtaining it legally but continuing to use it in treatment? Why would it be any different for someone struggling with a cannabis use disorder? So if you have leverage, then one of the first recommendations would be to interface with the physician who recommended the medical cannabis, and caution against recommending medical cannabis for clients with substance use disorders. We'll talk some more about how you would interface with that physician in just a moment. The physician may consider non-addictive medication alternatives. They might consider alternative administration schedules, dosage adjustments, or even referral to for a second opinion with a specialist. You might consider some counseling for harm reduction, and you might use alternative interventions to try and address some of the problems for which they're taking medical cannabis, as we discussed earlier. And you might refer them to an appropriate treatment or recovery group, or to a higher level of care if it's needed. Maybe they need residential treatment, for example, in order to quit and to stay quit. Okay, so here's some more on how to interface with the physician recommending medical cannabis for the client, for whom you have leverage. Now, I think there are some important things to remember. The physician may not have the same information that you have about the client. That's not uncommon. Sometimes the issue is that the client maybe didn't tell the physician about their 3 DUIs, or about the way that they use cannabis or how much of it they use, or they didn't tell the physician about their family history of psychotic disorders or any number of other things that you may know about as the evaluator. It's also important to remember that physicians are often pressed for time. They often have very limited time and a lot of work to do with the time that they have. They sometimes are not going to have the expertise that you might have as a mental health or substance use professional. Sometimes that's just not their area of expertise, and so your expertise could be very helpful to that physician and could potentially persuade them that a different course might be needed for a client. I do think that most physicians really care about their work and about their patients. But at the same time, physicians may or may not take your perspective seriously if you're not a physician but are a mental health or substance use disorder. You might not have as much clout with them as maybe another physician would. So what I would recommend is that you write a letter to the recommending physician. You would, of course, have to first secure appropriate consent from the patient. Now, the patient may decide that they don't want to consent to you interacting with the physician who recommended medical cannabis. That's within their right to do so. But if this is mandated treatment, then they're essentially refusing treatment. They're refusing to participate because they can't tie your hands. If they're saying, hey, I'm going to get my treatment, I'm going to participate in my treatment and complete it successfully because I want the thing that for which you have leverage, then they can't tie your hands and not allow you to do your job, not allow you to communicate with the other members of their medical team so that one entity knows what another entity knows and that information could be used hopefully for the better of the patient and everyone else involved. So you might actually potentially discharge a patient unsuccessfully who refuses to allow you to communicate with a physician who's recommending an addictive substance for them when they're in mandated substance use treatment. But the client will often agree to consent for that communication when this is explained to them and when they understand the reasoning for why you're doing it and the potential implications for them not participating. So when you write this letter, you notify the physician of the client's presence in treatment and the reason for their admission, their presenting problems, the referral source, and their diagnoses and symptoms, and you're very specific. So I've included templates in your handouts folder that I use in my own practice. Let's say that, for example, I'm working with a patient because they had a cannabis-related DUI. Then I'm going to say that, the client was referred to me by the Suncoast Safety Council after their DUI arrest, which was cannabis-related on such and such date, and that I performed a thorough evaluation using the following procedures. And then I might describe those procedures, hopefully hitting on those 4 data categories that we discussed earlier. And then I would say that in my best clinical judgment, the client meets diagnostic criteria for, and then I'd list the different disorders and their severity. It might be a severe cannabis use disorder, for example. I would then list the specific DSM-5 TR diagnostic criteria that the client meets, and I would describe exactly how the client meets those symptoms. Next, I would quote APA and ASAM guidelines about avoiding addictive medication options for individuals with substance use disorders and about the avoidance of medical cannabis as an approach for such individuals. This usually says something like, I would recommend adherence to practice guidelines published by the American Psychiatric Association and the American Society of Addiction Medicine, which state, and then I quote those guidelines specifically. I do this because, as I said earlier, a physician could potentially not treat your recommendations as seriously because you are not a physician. But if you instead quote guidelines from physician organizations, then that might mean a little bit more to the physician. You would indicate that your treatment plan with the patient will include psychoeducation and psychosocial interventions and alternatives to medical cannabis. You would discuss any urinalysis drug testing procedures that you're going to use, and you would ask the physician's office to send you a copy of the patient's records, including an updated prescription list, and you'd extend an invitation for additional collaboration. When you write this letter to the physician, you are essentially ensuring that the physician now knows what you know, and that gives them some liability, some responsibility to do something important with the information that they now have. Also, if they do respond to your request for records by sending you the records, then that proves that they received your letter and reviewed it in some way, or at least somebody at their office did. So what happens if the physician doesn't respond to your letter, or maybe just changes nothing? Well, then you're back to the same dilemma. You can't just, successfully pass the client on through their treatment, their mandated substance use treatment, when, they're still using cannabis, given that the clinical data available to you suggests that it's highly problematic for them. So you would probably continue to use your leverage in that case. And the way that I would suggest doing that is to go back to the patient, explain that the same dilemma still exists, and then suggest to them that the next step be that you refer them to a board-certified addiction medicine specialist or some other trusted physician with particular expertise in working with addiction for a second opinion. And you would send a referral letter to that physician with the same kind of information that you sent to the physician who recommended medical cannabis. And you would ask them for an opinion on whether medical cannabis is medically necessary for the patient, and or whether there are safer, non-addictive treatment alternatives available for the patient. You're doing this because if you yourself are not a physician, then you're really not qualified to offer opinions on what this patient needs from a medical perspective to treat conditions that are outside of your scope of practice. So you would really need to refer to a physician who hopefully has dual expertise. They both are appropriately credentialed to be able to offer recommendations about medication regimen for biomedical conditions. But on the other hand, they also have expertise in addiction that the physician who recommended medical cannabis may lack. In my experience, I've never had a board-certified addiction medicine specialist offer a second opinion for such a client and conclude that medical cannabis was actually medically necessary for that client. They've always concluded that it was not. And then that gives you the opportunity for that addiction medicine specialist to become the physician who now provides medical oversight for that patient. They might assist the patient with that non-addictive medication regimen, and they might collaborate with you. They might treat those conditions from a medical perspective while you provide your psychosocial interventions for those problems while the patient's in treatment. What if, however, you have no leverage? Your client has a moderate to severe substance use disorder, they don't want to stop using medical cannabis, and you have no leverage. As I said before, you'd meet the client where the client is at, honoring their autonomy, providing a harm reduction approach, just like you might do for a client with a mild substance use disorder who doesn't want to stop using medical cannabis. Now, some clinicians choose to discharge such clients, reasoning that they don't want the liability of working with a client who isn't compliant with their recommendations. I can see validity in that approach, but I favor the approach of meeting the client where they're at, rolling up your sleeves and doing the best work you can with them. I reason that they're probably better off working with you than not. Maybe in the course of treatment, the patient will reach remission status even if they're still using medical cannabis. Or maybe at least their problem won't get worse. Or maybe their problem does get worse, but maybe something changes in the course of treatment and they'll realize that they no longer want to use medical cannabis. Here are some examples of approaches you might use through that harm reduction paradigm. Consider using motivational interviewing to help the client explore and/or resolve the ambivalence about medical cannabis. Consider providing psychoeducation on the risks and benefits of medical cannabis, the effects of THC, the addictive potential of THC, synergism with or adverse reactions involving other medications, etc. Consider providing ongoing monitoring for signs that the client's medical cannabis use is becoming problematic or the client's relapsing with symptoms of a substance use disorder. For example, is there evidence that the client's over-medicated? Do they appear to be high, and is this noticeable to others? If so, how does it affect the client vocationally and socially? Is the client under the influence when driving or engaging in other potentially unsafe behaviors? while under the influence of THC? Does the client appear to have impaired motor functioning or to be struggling with short-term memory, motivation, energy level, or physical activity? Do they appear to be experiencing signs of possible respiratory problems? If any of these things are happening, then there's always opportunity to be able to explore them with the patient, to work with the patient to try and help them become aware of some of these things that they may not be so aware of themselves, and to plan and take action on them. You can also explore with the client what their end game is, as we said before, meaning the long-term versus short-term strategies and approaches that they'll use for their presenting problems. You can consider coaching the client on those psychosocial alternatives or supplements for medical cannabis. For example, what other strategies can a client being prescribed medical cannabis for chronic pain use to manage that pain? What other coping strategies are available for a client being recommended medical cannabis for anxiety, PTSD, or insomnia? And if you're competent to provide those psychosocial interventions, then maybe you would do so. And you could consider recommending that the client consult with their physician or medical team about other biomedical strategies to treat the same conditions that are being treated by medical cannabis, but that might be safer or more conservative options. And you can collaborate with the client on developing a preventative strategy plan. For example, how can we avoid driving when under the influence of medical cannabis? That's a lot of information that I've thrown at you, and I want to point something out here. If you look at this matrix, it really does work like a flow chart. There's a question, and then you either go to yes or to no, and then that reveals another question, which you then answer, and then ultimately you end up at an end point, regardless of what your answers to these questions are. So it's designed to try and work fairly easily for you, but let's use a few case examples here with this matrix. Here's our first real case scenario. Gabriela is a 53-year-old and has a diagnosis of multiple sclerosis. She participated in a mental health evaluation at the recommendation of her primary care physician due to complaints of depression, and was diagnosed with a major depressive disorder that was likely secondary to her MS. She was then referred to you for therapy for her depression. She mentions that her physician has prescribed her a mild dosage of medical cannabis to control spasticity. She denies any concerns about her cannabis use. Now, of course, with such limited information, it's very hard to answer the questions on this matrix, but let's approximate what we might do if we had more information. Let's start with the first question. Has the client been diagnosed with a substance use disorder? I circled no, because I don't think any information in the vignette suggests that the client has any symptoms of a substance use disorder. Let's assume that we've done a full evaluation and we find no additional evidence of a substance-related problem beyond what was described in the vignette. The next question would be, does the client want to stop using medical cannabis? I circled no, because it doesn't look like she does based on what we read in the vignette, but of course, in real life, we'd be asking very directly and confirming whether that is the case. Since the client doesn't appear to have a disorder and doesn't want to stop using medical cannabis, we meet her where she's at, using a harm reduction approach, just like we discussed earlier, and you see here on the matrix a bullet point list of some examples of approaches you might consider when you're operating from a harm reduction paradigm. Now let's move on to scenario 2. Alejandro was referred to you because of a DUI charge involving alcohol. He has a previous DUI that was both cannabis and alcohol related, a disorderly intoxication charge, and a possession of marijuana charge. He's court-ordered to complete outpatient substance abuse treatment successfully. He denies any concerns about his cannabis use, and when he heard that he'd be expected to avoid the use of illicit drugs while in treatment, he secured a medical marijuana card for ADHD. As with scenario number 1, let's start with the first question. Has the client been diagnosed with a substance use disorder? I think that the answer here is going to be yes. The information in the vignette, while no substitute for a thorough evaluation, suggests that Alejandro has used substances in physically hazardous situation and has experienced some negative consequences connected to his substance use repeatedly. He likely meets diagnostic criteria for at least a mild substance use disorder. The next question would be, does the client want to stop using medical cannabis? I think the answer is no, given that he just now got his card because he knew he'd be going to treatment. The next question is, what is the severity of his substance use disorder? This one's tricky, but let's assume that a thorough evaluation yields no additional evidence of a substance-related problem other than what we read in the vignette. If that's the case, I only see 2 symptoms of a substance use disorder, so I'd probably go with mild as my answer, but some clinicians might go for moderate. As you can see by this blue arrow leading from mild to the harm reduction box on the left, the preferred approach in this case would be harm reduction, because clients with a mild substance use disorder who are taking a potentially addictive medication and do not want to stop using it might be able to reach remission status with a harm reduction approach, or at least such an outcome would be more likely than if they had a moderate to severe substance use disorder. Now, it's perfectly okay for a clinician at this point to use their judgment and say that they'd rather use their leverage, which would take them to a very different approach detailed on the right side of the chart. The matrix serves as a guide and offers a decision-making process, but it doesn't completely remove room for varying approaches, of course. So, as was the case with scenario number 1, we would then consider these approaches listed on the left-hand side of this chart. Now let's move on to scenario number 3. Ron was discharged against medical advice prematurely in the opinion of the treatment team from a residential substance abuse treatment program with diagnoses of alcohol use disorder severe and cannabis use disorder severe. He sought treatment reluctantly when his wife threatened to leave with the children. He's 42 years old and had been using addictive substances regularly since he was 14. Upon discharge, he met with a psychiatrist due to severe depression and anxiety. She pointed out that because cannabis helped him to feel happier and less depressed during his 20s, he should consider it, and she wrote him a recommendation for a medical marijuana card. He's seeing you because his wife insists that he see a therapist. As with the other scenarios, let's start with the first question. Has the client been diagnosed with a substance use disorder? The answer is clearly yes. Ron has been formally diagnosed by his treatment team. The next question would be, does the client want to stop using medical cannabis? Probably not, given that he just obtained his card, but let's assume that we asked and he confirmed that he wanted to keep using it, which, by the way, was the case in the real case that this scenario is based on. The next question is, what is the severity of his substance use disorder? The answer is moderate to severe. This was clearly identified in the vignette. He actually has more than one severe substance use disorder. He has 2. The next question here is, does the counselor have leverage? Well, the client isn't seeing you for mandated treatment. Some clinicians have opined that in this scenario, we do have leverage because Ron's wife wants him to see a therapist, but in reality, Ron's wife only said that she wanted to go see a therapist, not that he must comply with the therapist's recommendations or must complete successfully or she'll leave or anything like that. And I don't know that a spouse's mere preference that he talk to someone quite meets the threshold for the definition of leverage that we're using in this matrix. So I'm going to go with no on this one. And that brings us back to the harm reduction approach, meeting the client where he's at. As I worked with him, I continued to plant the seed for what it would take for him to be ready to pursue a goal of discontinuing the medical cannabis, but otherwise provided treatment as usual. I did discuss my concerns with him, and the reason I had those concerns, I recommended that he allow me to communicate with a psychiatrist so that she could know about the extent of his history of problems with substances, but he declined. Now, you might at this point be saying to yourself, gee, does everything just end up with harm reduction on this chart? Is that how this chart works? No, it doesn't, and that leads us to scenario number 4. And now here's scenario 4. Dante is a 40-year-old male who presents for an evaluation in an effort to obtain his driver's license, which was revoked years ago in another state after his second DUI charge, which also included a possession of marijuana charge. He reported that he completed treatment about 10 years ago related to that DUI, but that the state has no evidence of that completion. He has smoked cannabis daily since he was a teenager. He recently obtained a medical cannabis card. He reports that he smokes about 2 to 3 grams of cannabis a day starting in the morning. When asked what he uses medical cannabis for, he reports that he has some work-related stress and sometimes has a difficult time falling asleep. He acknowledged experiencing tolerance, endorsed symptoms of cannabis withdrawal, acknowledged craving for THC when he goes without it for long, and admits to an extensive history of driving under the influence of cannabis. As with the other scenarios, let's start with the first question. Has the client been diagnosed with a substance use disorder? The answer is yes. There is clearly plenty of evidence of meeting diagnostic criteria for a substance use disorder in the description of this vignette. The next question would be, does the client want to stop using medical cannabis? Let's assume that the answer here is no, and that he'd like to continue using it, though again, we would of course ask him about this. The next question is, what is the severity of his substance use disorder? I think the answer is moderate to severe. Even with the limited information available in this vignette, I can pick out more than 4 symptoms of a substance use disorder. The next question is, does the counselor have leverage? I think the answer here is a solid yes. Dante is participating in this evaluation as a requirement to try and get his driver's license reinstated. He wants and needs something from you. You have leverage. So you are now instructed to respectfully use the leverage you have, obtaining Dante's consent to communicate with the physician who recommended cannabis. I'd recommend that you now write a letter to Dante's physician using the template I provided and described earlier. The next question is, does the client's physician collaborate on a non-addictive alternative? Well, we don't know yet, but let's walk through both possibilities. Let's start with the easy one. Let's say that Dante's physician responds by rescinding her recommendation for medical cannabis and begins offering alternative non-addictive treatment options to him. Well, great. Then provide treatment as usual. But let's say that Dante's physician doesn't respond or just doesn't change anything. Then you can require a second opinion from a board-certified addictions medicine specialist using the procedure I outlined earlier. Well, we have covered a lot of ground in this video. Hopefully, you're clear now on what the scientific evidence to date does and does not tell us about medical cannabis, and you have some strategies for applying that research as well as practice guidelines when addressing medical cannabis use among clients presenting for mental health and substance use treatment. You've got lots of additional resources in your handouts folder, including the decisions matrix, templates for letters to physicians, the positions of various associations, and other materials. If you have follow-up questions, feel free to reach out. See you next time.